And now I believe that we're going. You see it, Joel? Yep, okay. All
Yep.
right. So just want to make sure everybody knows we're in the right spot. So welcome everybody to the BigHearted Tour. This stop, San Diego. Unfortunately, we are not all together in San Diego. Thank you, COVID. I am coming to you from New Jersey. Valerie and Julie from the HCMA office. Valerie's coming to you from New Jersey. Julie's coming to you from Pennsylvania. And then we have our staff and faculty from UC San Diego who are all in San Diego. So we're going to be starting in just a few moments. I do want to go over some housekeeping items before I turn over the microphone and the unmute button to Jorge Silva. So number one, we are live in Zoom and we are streaming on Facebook. If you are a Facebook viewer and you would like to ask questions, you will need to log into the Zoom meeting. The link is provided above. So you can just come on in live and join us for the Q&A. We will not be taking questions from Facebook. Number two, we will not be giving, the physicians will not be giving medical advice on an individual case-by-case basis. These are general HCM informational sessions. So if you are going to ask a question that is very specific, yours truly will probably take that question and reformat it into something that would be less specific to you and more generalized to the question that you're trying to ask. But if you want to ask an individual question at the end of the session, when we are not broadcasting on Facebook and we are not in a recording situation, which we are right now, you can ask those questions off camera. However, they will not be able to give you individual case-by-case patient consult. You would have to contact them directly to get an individual consult. But if you don't want to ask a question for the audience to hear, you can wait until the end of the session and we will take those as anonymous questions. So without any further ado, I'm going to stop sharing right now. And I'm going to hand the microphone to our Center of Excellence Coordinator, or I'm sorry, Director at UC San Diego, Jorge Silva. Jorge,
Thank you, Lisa. Thanks for the invitation and being part of this tour. All of us are very excited to be, part of the big family of the HCMA and all the care that you provide, the strong force that you provide for all of these patients. And we're just so happy to join us today. Also, my friend, director, and fellow in crime, Dr. Eric Adler, who also sees a lot of our HCM patients, and he has a specific focus in one of the more advanced of the stages of HCM. Gabrielle Vaughn is one of our pediatric cardiologists that Radies at our neighboring institution, where she managed a lot of the pediatric HCM and deals with a lot of the stresses that the family go through. And John Su, who's jumped in, he will join us in a bit. He's one of our top electrophysiologists who manages a lot of the patients with ICDs and defibrillators and atrial fibrillation. And he's our go-to person for management of AFib.
Fantastic. Thank you so much. I forgot to mention one little thing. I populated a poll here for those who are already logged on. If you could please take the poll so we know where you're coming to us from and what your HCM point of view is. At the end of my presentation, I will go over the poll results so you have some time to fill that out. So tonight we're going to go through a couple of different topics. I'm going to just move my screen here for one quick second so I can go through the agenda. So yours truly is going to be presenting. I'm going to kind of go quickly through mine because you can look at a lot of different HCM Big-Hearted Warrior tours and you'll get some of the same information from my talk. But I do have a couple of special announcements tonight. I hinted to them earlier. This is a little bit late for some people on the East Coast because it's already 9 o'clock here. So I'm going to try to stay on time for this one. And I have a special announcement at the end of my talk and a special new offer. And then maybe there might be some Halloween surprises later on tonight. So you might want to hang out for after the sessions are done because things might get a little spooky around here. I don't know, heard a rumor. So we've got that to go. So I'm going to take it off now and I am going to start my presentation. Let me give you another housekeeping tip. And I didn't take my notes that I normally take with me, and I want to introduce two people before I speak. Valerie Ventry, who on my screen is over here, is our Center of Excellence coordinator. So she helps us keep our Center of Excellence programs up and running and all of our documentation in place, and has helped with coordination of the Big-Hearted Warrior Tour, along with Amy Mann. And we let Amy have off tonight from the actual meeting, and Amy is our meeting coordinator. who lucked out and picked the non-midnight version of the Big Hearted Warrior Tour from the East Coast. And below me in the what I call the Alice box on our Zoom machine is Julie Russo, our volunteer coordinator. For those of you who are interested in getting involved with volunteerism with the HCMA, Julie's going to help you find a program that fits exactly what you want to do for us and what we need done for you. So that's part of our staff who has been helping get this tour going. So let me do a screen share and we will start my talk. There we go. Okay, remember, you can keep taking that poll the whole time that Lisa's talking. So if you get bored, you got that to do. So this is our agenda for tonight. We are going to be doing an overview of HCM. We're going to be talking about sudden cardiac arrest, arrhythmias, and defibrillators. We're going to be talking about a matter near and dear to my heart, heart transplantation, and pediatric HCM, another thing that I used to be, and many of you as well. I want to take a moment to thank our sponsors for this event, remembering that when they came to the HCMA and we talked to them about sponsorship of this tour, it was supposed to be in person, and they've been really great sports about having to transition to yet another Zoom meeting. So we're really happy to have Myocardia, Boston Scientific, Cytokinetics, and Invitae as partners in this endeavor. And they've been really great to work with. So thank you very much to all of them. And so we're going to talk a little bit about HCM in numbers right now. I'm going to go over this really quickly because you're going to hear about this in some ways from our other speakers, but a lot of you have the experience of being misdiagnosed for a long period of time and not being appropriately identified as having hypertrophic cardiomyopathy. We know the most common misdiagnoses associated with HCM are athletically induced asthma, mitral valve prolapse, anxiety, depression, and most commonly, an innocent heart murmur. We know they're not so innocent. So we are trying to develop tools with our Center of Excellence partners to use electronic medical record systems to help identify the undiagnosed earlier by using the technology that we have at our hands and looking for things like family history of heart failure, atrial fibrillation, sudden cardiac arrest, transplant, or early death, along with some of these mimickers to help aid in the lessening the timeline to discovery of appropriate diagnosis. So how common is HCM? We used to think it was 1 in 500. That was based on echo data many years ago from Dr. Marin. He did a first study in Minnesota looking at, or I'm sorry, in Chicago was the first one, the Cardia study, and then rural Minnesota, and then other parts of the world looked at the same data. And if you looked at any echocardiogram that came across your desk, 1 in 500 of them had diagnostic criteria for hypertrophic cardiomyopathy. However, time progresses, technology gets better. MRI enhances our ability to see the myocardium more fully and see areas of the heart that we couldn't measure very well with echo. And then we have the advantages of new genetic testing. So based upon enhanced imaging and genetics, we now know HCM to be probably closer to 1 in 200. There's a question mark there because we're still not 100% sure what that number is. So if we're to take these numbers, we're looking at a minimum of 750,000 people in the United States alone who have diagnosable HCM. Our problem and our challenge is only about 120,000 of them are actually in care for hypertrophic cardiomyopathy. So there's a lot of people out there running around with big, thick hearts and HCM, and they don't even know it. So hopefully the tools that I talked about in the first slide are going to help us find more people to get into proper treatment pathways. So this is a really important slide to me for this particular talk because we're talking to somebody who knows a lot about this particular topic today, and that's Dr. Adler. So we know that the sarcomere is responsible for most of the HCM that we see, and that's the contractile proteins within your heart that actually make it contract and relax. We know that there are 13 major genes and a couple of other ones with over 3,000 different mutations that cause HCM in about half of the population. Then there's another group of you that don't have an identifiable mutation yet, and it may be in this region of the heart or it may be in another region of the heart that we haven't identified yet. So that's pretty much what we're talking about in terms of hypertrophic cardiomyopathy. And for the purpose of tonight, this is really where we're staying. But that doesn't mean we can't acknowledge the fact that there are things we refer to now as HCM spectrum disorders, which means on imaging, echo, and MRI, the hearts look very much like hypertrophic cardiomyopathy, but they have a very different genetic underlying cause. One of which is something called AMP kinase. Another is Fabry's disease. And Dr. Adler has spent a great deal of his time and his career researching something called LAMP2 or Dannon's disease, which can look like a very extreme presentation of HCM in young males. It looks a little different in females, but these disorders have different pathways. And in fact, they're working on different therapies. Fabry's has a therapy of its own, and there's a clinical trial underway right now for Dannon's disease. Other non-sarcomeric ways that the heart can look like HCM can include amyloidosis and sarcoidosis. So if those are your diagnoses, you're not going to hear a lot about them tonight. We just want to acknowledge that they're there. And this is one of the reasons why genetic testing can play an important role in your treatment and your care. So in the pathway of HCM care, there's lots of different things that can happen for an HCM patient. You can have high risk of sudden death. You can have progressive heart failure with obstruction. You can have end-stage or non-obstructive advanced heart failure, atrial fibrillation, stroke. And some of you are going to be asymptomatic, low risk, and just gene positive. And then you're going to need to follow up over lifetime with echo and EKG and a checkup with a cardiologist once in a while. For the rest of them, you're going to be looking at some pretty invasive procedures and drugs and a lot of different possibilities. It's really important to know where you fit in that. So why is it important to have a cardiologist on your team that really understands? Well, in part because most community cardiologists don't see an awful lot of HCM. In fact, on average, the average cardiologist has 2,000 patients in their practice, which means in general population, out in your community, about 10 patients in that doctor's practice are going to have HCM. But we just talked about how different the pathways can be. So what is the likelihood that the doctor down the street from you is going to see 10 patients just like you? Probably not very, very much. And when you're dealing with these complicated numbers, you have a situation where if your doctor has not seen somebody else who's obstructed, well, maybe they're not going to know what to do with you so well, or if they've not seen somebody with non-obstructive HCM, or they haven't managed a lot of AFib patients with HCM. This is why we developed the Center of Excellence concept. And probably about 2004 or 5, we really pushed to grow the Center of Excellence process. We had started with 5 or 6 programs, and that just wasn't enough to serve our population. So as of October 2020, we have 41 centers of excellence. For a full directory, visit the website at 4hcm.org. And these programs are growing. We have like 8 applications sitting on our desks right now, trying to figure out how to do site visits via COVID times. That gets a little difficult, but we have centers all over the country, and soon we will have some more all over the world. So stay tuned for that. What do you get out of Center of Excellence? Well, in the case now where it's going, how'd you get that picture? LinkedIn, actually, if you want to know. So this is how we envision an HCMA recognized Center of Excellence. We need a hocomologist, somebody who's going to be the gatekeeper for all your HCM related care and making sure that there's good coordination between your HCM physician and any other area that you might land in when you're in a medical situation. So yes, I use stick figures. I like this slide. So when you go to an HCM center, you go through imaging, you get an evaluation for electrophysiology, heart failure, genetics, hopefully mental health services. And you might land in different buckets at different times of your life. HCM doesn't go away. It follows us through life. I was 12 when I was diagnosed. I got to go through everything while having HCM, including maternal fetal medicine and advanced heart failure and EP. We go through different paths at different times, but we need to come back to our hocomologist and be coordinated so that we don't get lost in EP because we have arrhythmias. Yes, we need EP, but we need our HCM physician to keep an eye on the muscle. And we might go to surgery, and it might be cardiac surgery or it might be knee surgery. And we're going to need a cardiac clearance, and we're going to have to be careful during anesthesia. And we're going to have our physicians communicate clearly about what's in our best interest. So it's really important that this structure is maintained and that there's really tight controls over how patients get their care. So this program works really well. We know it because we've got lots of years of experience. But are all programs the same? They're not. Some programs are very, very comprehensive. Some are what you're going to hear in the future referred to as primary. And then you've got your home-based cardiologist. Now, that first slide that I talked about your home-based cardiologist, you might think I was saying don't have one. Not true. In fact, the hometown cardiologist is critically important to the continuity of care, but they shouldn't be leading the charge on what to do about your HCM. That should be left to a center of excellence. But if you land into your local ER with a new onset of atrial fibrillation or some arrhythmias that you don't understand, you want that local doctor to know what's going on and to be coordinating with your center of excellence. A high volume center of excellence or comprehensive program includes everything from diagnostics to transplant, pediatrics, maternal fetal health, and everything else that you could possibly need. Primary HCM centers may not have transplant programs. They may refer out for their myectomies or alcohol ablations, but they can do diagnostic, advanced imaging, testing, genetics. They can do ICDs, but they may not have that high level to do the actual surgeries or the transplants. So it's really about what the individual patient needs. So what do we know from the patient perspective about a center of excellence? We've surveyed thousands of patients and we've asked them, what do you think about this? They tell us that they feel more supported by a center of excellence and that they have improved quality of life, both physically and emotionally, because they finally feel understood and they know what the pathway is going to be. We know from their perspective, as well as from clinical data, that the outcomes for invasive procedures have lower complication rates than those being done at local community centers, and that patients have the ability to participate in clinical trials, which is very important to many of our patients. We know that the high volume outcomes have been proven out in medical literature, that if you have a myectomy at a low volume center, it's a 1 in 8 catastrophe. When you have a myectomy in a high volume center, it's a 99.5% good outcome. We like those odds a little bit better. We know that patients are going to get the appropriate level of care. More testing, more procedures is not always better. In fact, it can be very harmful to patients if they have unnecessary cardiac catheterizations, are given devices that they don't need, or medicines that they don't need. We also know that when you go to a high volume center of excellence, there's a really good chance that you're going to be taken off of medications that have been either inappropriate or contraindicated for those with HCM. Excuse me, I left my water in the other room and I have to cough. Sorry about that. So I'm going to pivot now and talk a little bit about some of our social media programs. If you're watching us on Facebook right now, you know where to find us on Facebook. But if you're not there right now, you can go to our official Facebook page, and from there you will find groups. We have individual groups that are associated with the HCMA, and you will find that they all have the same look and feel. There are some programs and some pages that kind of act like they're us, but they're not us if they don't have our official logo and our artwork. We will be building out new programs in the coming year, probably year to 2 years, called HCMAI, which are international programs. And in fact, maybe in the next 2 weeks, we're going to launch our Spanish language poster as well as our Swedish language poster. Not the one you expected, I bet, but we have a group of women in Sweden who are actively building a support system over there. So we're going to be linking them also into our Facebook community as well. They'll have their own individual page for Sweden. Excuse me. So we're building out our online support group program, and I'm really happy to announce that hopefully next week, Julie and I will get to the end of this project, and we have approximately I think 14 or 15 trained online support group leaders. And if all things go the way we think they're going to go, you should be able to sign up and participate in a support group Monday through Thursday every week of the month. So you should never be more than 24 hours away from support if you need it. You need to talk to a group of people. Each group is going to kind of have its own flavors. So you might find out that you like person A's group because you like the way that they handle the conversation. We're kind of looking at them like radio shows, kind of with a host and a personality there. So we're going to have bios, and you can kind of take a look at who's running the programs. We will have a variety of different topics from pre-myectomy. I will be leading those talks once a month. And then we're going to be doing communicating with your family, living with HCM and your occupations. We have a lot of police officers involved in this program, which is pretty cool. Writing and journaling for mental health and well-being, communicating with women only or communicating with men only about intimacy issues related to HCM. We're going to go everywhere. We're going to talk about everything. So we're inviting you to join us for these programs and give us your feedback. It's a new program, so everything you tell us, we're going to be really looking for feedback so we can build the programs and make them stronger and better. So next year, we're building out our peer-to-peer Big Hearted Friends Network. Many of you have called the office and asked for me personally to put you in touch with another person with HCM in a similar situation. After about 15,000 of you, it's getting a little hard to keep you all straight in my head. So we're going to use technology to help us. Think of us as the eHarmony of HCM connecting. So you can tell us what you're looking for. The mentors will tell us what they're looking for and what they want to give, and we'll try to match you up. It could be a phone call. It could be a weeks-long relationship, a month, a year, a lifetime. It's just finding somebody who you can click with and that you have that level of support outside of your family. I don't know if any of you have been following the Tales from the Heart program, but we're going to be including more of the share your story component in Tales from the Heart coming up. In the past Tales from the Heart podcast, we've talked to physicians, and I have a standing appointment once a month with Marty Marin and once a month with Harry Lever, where we dive into deep topics on HCM. So you can join us for that. The Share Your Story program is going to take on some new meeting. We just actually had a meeting earlier today to start organizing filming, where we're going to be taking individual stories and bringing them into our brand new website, which should be available first quarter of next year, where you will actually be able to log on and view people's experiences with various aspects of HCM, as simple as screening for echoes or having a cardiac catheterization. What does it feel like to that person? What is shortness of breath to you? And people will tell you exactly what they explain it as. Myectomies, transplants, mental health issues. You'll be able to go to the HCMA website and hear directly from people who are living with HCM, so you don't feel so alone at 3 o'clock in the morning when you're freaking out because tomorrow you have a cardiac cath coming up. We'll be able to get you through that no matter what time of day or where you are on the planet. So look forward to that. If you want to share your story with us, you can email Julie at 4hcm.org and say, hey, I want to share my story too. And we will find ways for you to do that. So we've got that program coming up. We kicked off our 1-year anniversary of the Elizabeth T. McNamee Legislative Subcommittee. We will be launching some training in December probably, and we'll be doing much more training in the first quarter of next year. We're kind of waiting for that thing that's going to happen next week to kind of go away, because we're talking about state level legislation, not federal so much. So we want to let that kind of little election kind of get over, and then we can get everybody else involved in state level legislation, where we want to accomplish what we've done here in the state of New Jersey. And that is to use the well child examination as an opportunity to identify those who are at higher risk for heart disease and ensure that they get a referral to cardiology for the proper assessments. It's not just for HCM. There are other diseases as well that need to be identified early on, but we're not mandating any particular test. We're mandating that the physicians take a training course and that the state require that training course so that they can identify these different forms of heart disease and make referrals appropriately. It doesn't add any cost. It's bipartisan and it's going to help families. We also want to support legislation that supports good AED, CPR, and Good Samaritan coverage, and those are on state level issues. On federal levels, we want to make sure we have our pre-existing conditions covered no matter what comes. We also want to make sure that we're advocating to the FDA, CDC, and other agencies on matters related to clinical trial discoveries, patient safety, and other related items. If you have not viewed the PFDD yet, I encourage you to go over to YouTube and /HCMA USA and watch this program. You're going to see some of the people that were featured in the PFDD also show up on our website in the new form. So you'll be able to learn a little bit more about their story, and you'll be able to see what we're building in the future in terms of how we're going to be educating and raising awareness about HCM. Now I'm coming to the end of my talk and an announcement, and this is really cool. Okay, so obviously I want to say thank you to everybody, our partners at UCSD, our partners at our recognized centers of excellence, our staff, our board, our volunteers, and of course, Brandy, my donor, for who out with I wouldn't be here. But this yellow banner that's new. as of today, if you log on to the HCMA website and you go to our store and you're an active member, you will be able to submit an order and get a free, absolutely free 23andMe Ancestry and Health Kit. There are no strings attached here. This is not an HCM specific test by any sense of the imagination. It's just kind of a fun genetic test that you can get. And it is only for members, and it's one kit per family. And we have 1,000 of them to give away. So I would encourage you in the next 24 hours or so to go ahead and go to the website and sign up for that. If you say, hey, I want that, and you're not a member, you can become a member and then just go order that, and it's free. So that's a good thing. No orders, we'll get a link to the actual kit after we confirm membership. And this was an in-kind donation from one of our sponsors, and there's no strings attached. You don't have to disclose, you don't have to share your genetic information with anybody if you don't want to. It's just for fun, and it was a nice little giveaway. So think of it as an early holiday present. And on that note, I'm going to hand it off to Jorge Silva, who is going to talk to you about all things HCM. Jorge,
Thank you, Lisa. Yep.
Thanks.
Here we go. So let me see if I can do this. Give me 1 second.
Absolutely.
I think you're seeing my presenter view. So let me.
Yeah. So you might. Do you have two screens?
Yeah.
So you want to click back on that one and then swap the screens.
Yeah. Give me 1 second.
Technology.
Yep. Okay.
Oh, while you're doing that, I will tell everybody where we're coming from. So I'm going to end the poll. Oh, Jorge, can you pull your screen down for just 1 second so I can show everybody where we are? And then I'm going to share the results. So we have a group of people coming from the Northeast, Southeast, Southwest, Midwest, West, Europe, Australia. We got the world, guys. It's a small group, but we got the world. 67% are patients themselves. 11% are patients and family members. 11% are somebody in the family has HCM. 6% are medical providers. 6% work for industry, and 28% of our viewers are diagnosed within the last 2 years. 56% are on meds. 50% have devices. 17% have had an alcohol ablation or myectomy. 33% have AFib. 22% of us have lost a family member to HCM. 6% have had a heart transplant, and I didn't take that, so it's higher. So statistically, we're cool tonight. 56% have had genetic testing, and 6% have been told to get an ICD but haven't done so yet, and 11% have been advised to get septal reduction therapy and have not done so yet. So we have some people on the fence making decisions tonight. So that's just a peek as to who we are, and I'm going to stop the share. Jorge, back to you. So sorry.
No problem. That was great information. Okay, I think you can see it now.
We got it. Great. Thank you.
Perfect. Well, thanks again, Lisa, for the invitation. Very happy to participate and be among the other centers to kind of give it an in-depth view about what entails to have HCM and all the tools that we have nowadays to diagnose, manage, and change the quality of life of a lot of our patients. So this will be just a brief overview of what we do here at UCSD when we evaluate patients with HCM. So a little bit about who we are. Probably a little that is known that UCSD has been kind of pioneering the discovery of understanding the physiology of patients with HCM. Back in the late 1960s, Dr. Eugene Bromwell was brought from the NIH to be the Department of Medicine chair, with his friend John Ross, who was the chief of cardiology at the time. And they brought all the wealth of knowledge of understanding how HCM works and what causes it. At the time, there was no echo, so a lot of invasive tests were done in understanding what causes the muscle to grow below the valves themselves, and understanding more about the physiology. Along with them, also Dr. Morrow, who was a surgeon, developed the first techniques on how to do the resection of the extra muscle, and at a point, they would see dramatic improvements in the reduction of the gradients. Now, in terms of who we are in the California system, we are the fourth largest health system in the state. We are ranked among the top 50 programs here in California, and we're part of a bigger set of programs that perform high volume in terms of heart transplantation. We have two major hospitals. The one on the left side is our cardiovascular center that has 54 beds, and that's where all the imaging tests, all the procedures, all the diagnostic tests, and all your clinic visits are centralized in there. And that's also when people stay for any afternight or overnight visits for our procedures. And hopefully and happily, we've been also ranked around the region to be among the top cardiovascular care providers, as well as a high performing volume for heart failure procedures and diagnosis, as well as for transplantation. And on the other side, we have our newest building, which is the Jacobs Medical Center. It's a 400 bed hospital that cares for more advanced medical conditions that are not related to heart disease, but all patients with heart disease can be evaluated there as well. More advanced care for women that are high risk for pregnancy or high risk of giving birth, with that, for example, with HCM. And for that, we do a co-joint OBGYN conference where ourselves as cardiologists and the OBGYN discuss high-risk cases. So it's important when you see your cardiologist that you talked about in length about your symptoms. I think this is something that is very key to understand how you feel and also what are the proper diagnosis tests. So defining your symptoms is very important. Many symptoms can arise from being just short of breath with minimal efforts, or being fatigued or dizzy, or having just unprovoked heart racing sensation. Sometimes feeling like passing out, or chest pain or chest pressure with or without any exertion could be some of the symptoms you can have. And the symptoms can sometimes be very mild, sometimes they don't occur. So there's always a day-to-day variation, and be aware of that. So sometimes we advocate for patients to have some sort of a symptom diary to better understand what's provoking, what's triggering their symptoms. And also it's important to understand that there's a lot of research where that it says that women can manifest more severe symptoms than compared to men, and also presents to our clinics with more advanced disease stages. Also, it's important to define your condition. And this is by the use of echocardiography. We use echo as a main tool to diagnose, to observe how you're responding to treatments, how you respond after our certain procedures. And after we do also some follow-up tests to see how the heart is changing. We define hypertrophic cardiomyopathy by the thickness of the ventricles. And anytime you have a thickness of greater than 1.5 centimeters, it is likely that you might have a hypertrophic cardiomyopathy. And if there's a family member in your lineage that might have a history of hypertrophic cardiomyopathy or sudden death, anybody who has a thick heart of greater than 1.3 centimeters is also considered to have a hypertrophic cardiomyopathy. Important also that this has to be in the absence of any other medical conditions that might relate or trigger the thickening of the heart. Now, the vast presentation of HCM it's a wide spectrum. As Lisa mentioned, there's many genes that are involved in developing the condition, and you can see a vast array of morphologies of the heart itself. Commonly, we see the more severe forms when they have a very thick ventricle in the midsection that covers the entire base to the apex. Some of the other forms where just the base is being thick, and sometimes we see this very commonly in elder patients or more advanced age. We also see commonly sections of the heart that just, the tip of the heart is just thick, and there's really no symptoms of obstruction, but many of these people with this type of heart have many palpitations, so chest pain. And some other percentage of patients also might have significant thickening of the heart, but there's really no issues with obstruction. The first two symptoms are more commonly related to symptoms of obstruction, meaning that the blood flow path coming from all the blood from the lungs and empty to the rest of the body is obstructed by the thickening of the muscle, or maybe interaction between the valves and the muscle itself. Along the lines of only just also the having the thickening of the muscle, there's also other changes in the structure of the heart themselves. Many patients can sometimes have outpouchings of the tip of the heart, where these outpouchings can lead to just stasis of the blood and strokes potentially. They can also have abnormalities in the valves themselves being very long, or they can have multiple papillary muscles. They can also have multiple abnormalities in terms of the blood vessels that feed and give all the nutrients to the heart, where they become really engorged, and patients can have significant amount of chest pain or discomfort. As the disease sometimes progresses, you can see more scar tissue, and this is detected by MRIs, or sometimes you can see by MRIs other abnormalities that that people can be born with without even knowing. So defining your anatomy is a key component. And for that, we rely on echo, as we talked about, not only just focusing on the thickening of the heart, but also the interaction of the other relying structures, the upper chambers of the heart, as well as the valves, and all the attachments of the valves have, and as well as the attachments to the muscle, how they all interact, how the valves behave when your heart is beating, whether this is the lower chamber valves or the upper chamber valves, and also the presence of obstruction, whether it's just when you have symptoms at rest or when we provoke any symptoms like, for example, bearing down. So all the information that we get with echo is a key component to just understand how the heart behaves and also how it potentially might respond to treatments. And also just besides, as I mentioned, just that not only the structures of the heart muscle and the thickening of the muscle is important, but also just how all of these components interact with each other when the heart is beating. Many patients can have, as I mentioned, multiple muscle bands that can attach to the valve and cause an issue with obstruction. And sometimes these won't respond to medical therapy. Some other cases where you have thickening muscle attachments of the chordae to the valves themselves, and there may be a misaligned, and that can lead also to significant obstruction. And sometimes also these will not respond to medical treatment all the time. So it's important to understand the type of heart that we're dealing with, how this relates to your symptoms, and what are the best therapies. This is a case, for example, of a patient of mine that was sent because of difficult to control blood pressure, and his cardiologist noticed that his heart was thick. You can see on the video that's really the blood flow path is just not really having no issues, and his pressures inside the heart were really more on the normal range. But when we put him on the treadmill for 9 minutes, you can see the significant elevation of pressures, and we saw a significant amount of obstruction. This is at peak heart rate, even at lower heart rate. Once he was just after the treadmill, he was stopped, he was having still some symptoms. And this really correlated to the symptoms that he was having. So doing exercise tests, I think, is also a key component of understanding your symptoms and how your heart behaves when you're doing your daily routine, your demand. And it's important to understand that when you see a specialist, an HCM or a cardiologist, and they do more extensive testing, they're not only just doing an echocardiogram at rest is just enough. Doing different maneuvers, whether you're about solving or bearing down, or you're doing a standing maneuvers, it discloses and unmasks more of the obstruction itself. And here in the laboratory, you also tend to do all these maneuvers as well as take post-exercise, so post-treadmill running exercise images to really identify if people have obstruction or not. This has significant connotations because if you can prescribe the amount of exercise a person can do with these tests, it changes in a good way their quality of life. Many of our patients want to keep on doing physical activity. They want to engage in social activities, and for them to be as active as possible is a key thing. So exercise testing can give you some sort of a prescription about what is the best range of your target heart rate where you have to keep so you can avoid any symptoms of obstruction. It also helps us to decide if you have any irregular heartbeats that might occur during the exercise. The exercise tests also help us to see if the therapies are responding. Many times we do escalation of medication doses or of the concentration of the medications and see if people are responding. And that also leads us to say that if we need to keep on adjusting the doses is one thing, but if we reach a point where we cap the doses and no improvement and we see significant still obstruction, then maybe you need a more aggressive form of therapy. Now, advanced imaging is something that we're proud to have here at our institution, and MRI with the help of Dr. Paul Kim has been a key player in terms of defining the anatomy of all of these patients. MRI, because it has a better resolution to identify the pathology that we find in these hearts, we can identify the valves, the upper chamber, the lower chambers of the heart, as well as the major blood vessels. We can identify the presence of fibrosis, and also that can help us stratify people that are at risk for sudden death. Fibrosis and scar tissue have been shown in many studies that the larger amount of scar tissue, and this is just by lighting up the regions of the heart as you see in those white marks, the more you have that, the more the risk of having irregular heartbeats that could be lethal and potentially put you at risk for death. Um, Also, we've seen that as in subsequent studies that have serial MRIs through the course of the lifetime, they can see progression of the disease by forming more scar over time. And these hearts are potentially at risk for developing heart failure, becoming very insufficient to provide your daily needs of demands. So it's important to have a serial monitorization of with your cardiologist and your HCM specialist to rely on how your symptoms are changing over the course of time, and if you need repetitive testing or inclusive more advanced imaging. This is a case, for example, that I've seen recently of a patient that was just complaining of chest pain. He's an avid soccer player, but he will always have a little bit of chest pain and some palpitations. You can see on the MRI there is a thickening of the tip of the heart itself. And when we did the lighting agent or the contrast agent, you can see the significant scar tissue at the tip of the heart itself. And this explains quite a bit of the symptoms. Other technology that we have at our institution is the facility to assess the amount of blood flow that occurs throughout the heart, whether every single beat, if it goes forward or probably goes back into your lungs, we can quantify that amount. We can give estimations of volume of blood volume as well. Um, and as I mentioned before, defining the categories of your anatomy and the advanced disease is important by integrating different imaging modalities. I think also it's important, as Lisa mentioned, defining your genetic profile, and it's a key component in every evaluation that we get. Do genetic testing. Nowadays, there's a lot of significant amount of commercial available testing, and some institutions also offer free testing. And with that availability, we can identify people that are carrying the pathogenic genes, but also identify family members. And how are we going to serially monitor those family members? Many times we can see that over the course of time, and then this is a recent study showing that if people, family members that have the gene, but they not develop the disease over time, they can still start showing manifestations of HCM. And in this study, the average time when somebody had the gene detected, but no changes in the heart, it took around 8 years or so, an average time to develop changes in the structure of the heart and develop symptoms. So it's important. I think it's an important value having the genetic testing available. The other reason to have genetic testing done is because there's multiple copies of what it looks like HCM. One of the major interests that my colleague, Dr. Adler, has is on Danon disease and developing therapies. These are very thick cards. Another one of my colleagues who has deep interest as well is on Fabry disease and amyloidosis, which is, these are thickening of the heart, not because the muscles are thick, but this is just because there's a lot of substances and or perhaps byproducts or discharge products from the cells that accumulate inside the heart itself. And these have different approaches and treatment options. So defining your profile based on all the testing that we've done, from your history, your symptoms, your imaging tests, as well as your genetic background, can give us a better idea how to best manage you. As is a presence of scar tissue and risk of sudden death, you will be seen by our electrophysiologist to consider for an ICD. Whether you have more advanced symptoms that are not responding to medical therapy and you have more symptoms of shortness of breath, that classifies you in the category of having heart failure. And sometimes this heart failure can progress to an end stage form and potentially transplantation. And fortunate enough, here in our institution, we can offer the breadth of scope of managing from the spectrum of HCM, from either just sudden death until even heart transplantation as well. And other patients that have atrial fibrillation and stroke, what Dr. Sue will be talking about briefly, we have opportunities to offer treatments, whether medical or invasive as well. And I think it's important to realize that the spectrum of HCM is, and the profiling of HCM changes over time. The younger that you are when you're diagnosed, the more chances of developing more of the burden of the complications associated with disease, whether this is arrhythmias itself versus or developing of heart failure, or the risk of developing atrial fibrillation. These changes over time. And the older you are diagnosed, you're not exempt of developing also these burden of the condition itself. And it's important also to recognize that as I mentioned, with exercise testing, if you have significant symptoms, those people that have provoke symptoms with the exercise test also are at risk of developing insufficient hearts or hearts that are not able to pump enough blood for the daily demand, and those require more aggressive intervention. And it's noted that around 50% of the patients can develop significant heart failure symptoms. And so I think it's important to be cognizant about what are the treatment options at that point in life. I think it's also as part of HCM itself, defining your lifestyle and your treatment options. It's a key, it's integral. There are many research studies showing that exercise is beneficial for patients with HCM. Just knowing what is the right prescription and the right target for your capability of doing exercise. Many of them have shown that you can improve your endurance. There's no risk of developing worsening arrhythmias. And this also improves significantly the quality of life. And in some cases, and depends on the type of exercise, changes in the structure of the heart also can happen. I think it depends on what type of a sport you want to address or what kind of activity that you have that conversation and you have a shared decision about what is the best sport that you want to do. Because many of the sports or many of the exercise activities have different connotations in terms of the impact on the heart. Some of them can increase more your heart rate compared to others. Some of them can increase more your blood pressure than others. And I think having a one-to-one discussion with your cardiologist and your HCM specialist is a key component. Here at our institution, we have a very strong and cardiac rehabilitation program, but it not only talked about just your lifestyle options and your meal options, having an active cardiologist and dietitians as well, but having a focus group where everybody shares your same symptoms and conditions, and you have a psychological information just to manage your day-to-day symptoms, and also having supervised exercise routines at our institution as something that we are proud to offer for many patients. With all of this, we also define your treatment option, right? And so if you fall in the category where you have an obstruction, meaning the blood flow path through the heart is difficult to go through, whether it's at arrest or provocable, we always used to treat with just medications. We can always escalate care with medications depending on how you're tolerating one or the other. But if the symptoms persist, then you might need more invasive therapies. One could be surgery, or the other could be an alcohol septal elevation. And both options are offered here at our institution.
We appear to have a technical difficulty. Jorge has frozen up. Okay, hopefully his technology will come back online in just a moment. And while we wait for that, I'm going to do a slide stop. And hopefully that will work. And hopefully that will work. 2020. COVID and complications. This is interesting. Hey, Eric, you want to walk down the hall and give him a nudge? There it goes.
Okay.
Okay, we lost him and now he came back. Okay, so we're just going to pause here for just a moment and say 2020. This is all we have to say about that. Sorry about the technical difficulty. He will be back in a moment, I'm sure. And we will get the conclusion of his talk at that time.
Are there any questions?
There's no questions posed as of right now. If anybody has any questions, they can use the Q&A box at the bottom, not the chat box. So there's a Q&A box. You can put your questions in there and we'll be more than happy to address them. I am sure we will have Jorge back with us shortly. And while we're waiting for him to come back, is he back? Yep. I just changed my screen. Okay. Hey, Jorge, where'd you go?
So my computer just decided to reboot.
Oh, well, that was a really good time for it. Keeping me on my toes here. I'm like, quick.
I'm very sorry.
You sounded like you were doing an old-fashioned like rap thing with that. Like,
I have your slides. Worst comes to worst, Jorge. Do you want me to put them up?
I have him here. It's just, I don't know. Out of the blue, it's just my computer just went black.
Okay.
Ooh.
It must be some Halloween spook thing.
This is Halloween.
It is Halloween. Let me share my screen again.
Okay.
Very sorry for that. I was just going on a rant, and unfortunately, this just decided to stop.
That's okay. It's 2020. These things happen.
Yeah. Okay. Sorry, they didn't. Okay, we'll see. Okay, here we go. Can you see it?
That's exactly where you left off.
Yes. So as I was mentioning, there's the options for treatment differ based on your morphology of the heart and how the symptoms manifest and whether you have obstruction or not obstruction. Right now, we were talking about the obstruction option, that nowadays we have a vast array of medications, which traditionally start with some beta blockers or calcium channel blockers, but then might be newer medications out in the market soon that can help relieve the symptoms as well. However, there are many patients that despite symptoms persist, and you might need more aggressive interventions. And this relies on the fact that the anatomy is very different for each heart to heart, and not all of the hearts can respond to medications. And objectively, what we want is just to improve your quality of life and your survival. Other type of morphology or other type of heart structures do not obstruct, and those patients can have also significant symptoms. And in those cases, sometimes, unfortunately, we just continue treating their symptoms with what the guidelines recommend and trying to preserve their function. But over time, sometimes these hearts develop to have weakening muscles. And for those hearts, we always consider transplantation as another resort. Um, so in terms of the medical therapy, as I mentioned, one of the tools that we use in our institution is the use of disopyramide. And the use of disopyramide has helped us quite a bit in patients just having an improvement in quality of life. Also, although it is a big commitment for them to take a 3 times a day drug just to relieve their symptoms. And they notice that when they stop taking the medication, they get quite symptomatic. Some people, as I mentioned, will not be responsive to treatment, so they might need more aggressive interventions or heart transplantation. In terms of disopyramide, here's some cases that I've treated with, and older patients, especially, that they do not want to pursue any invasive therapy, so they want to take more just medication, and they're happy with that. We can see significant reductions in the pressures. This is an 86-year-old woman that I saw that she had a significant pressures inside her heart, 180 millimeters of mercury, that after taking the medication, her pressures came down around 30. And you can see also the blood flow path was just uninterrupted in those cases. We're very excited though what's coming up on the pipeline, and probably next year, which the new medication called mavacamten, which has shown significant reductions in terms of the pressures inside your heart, improving the quality of life and your symptoms, and dramatically reducing with exercise the obstruction of those hearts. So we're very excited about what start using this medication once the sense becomes available as well. Part of it, I think, is not only just focusing on medications as well as trying to improve your quality of life, but I think all HCM patients deserve a close attention in providing excellent care to different services that an HCM center can give, whether you need more advanced imaging techniques to detect your condition more precise, whether you need more management for arrhythmias or atrial fibrillation, whether you need surgery or interventions, the genetic counseling and screening, whether you need guidance through a difficult pregnancy or potential difficult birth. We have that as well at our center. And also the key components of the psychological and the psychiatric and mental health, it's integral for us. And all of these are part of this is the entire team that are key players, and all of them are self-specialized in each of these components that care for patients with HCM. They're interested in treating patients with HCM. Dr. Adler and Dr. Pretorius are our medical and surgical directors for advanced heart failure and transplantation. Dr. Green is our director and primordial physician for ICD and device management. Dr. Su focuses significantly in atrial fibrillation. Dr. Kim and Dr. Blanchard are our advanced imaging physicians, and Dr. Bond is our pediatric cardiologist and with a focus in ACM. Along with this, just spearheaded by our chiefs, Dr. Mahmood, who's the interventional cardiologist and performs many of our alcohol septal ablations, Dr. Madani as well, who's in charge of performing many of our myomectomies as well. So by and large, we're happy to say that in this day and age, providing a comprehensive care, multiple treatments available, over the few decades, the disease mortality has changed dramatically, and with all the opportunities that are out there to treat patients. And I'm happy to say that overall, that we can provide all of these treatments at our institution. And I think all of us are just interested in improving your quality of life and the survival of patients. And I think I'll stop there.
Thank you so much. I love those 4D images. That is like really cool stuff. You can actually see the turbulence of blood flow there. And I think that is really kind of different. Might need to steal some of those images for the website. Okay, next up, we're going to talk about kind of keeping with our Halloween theme, kind of the scary topics, arrhythmias and HCM. We want to talk about a real holiday thriller. So let's Dr. Su share his slides, and we're going to talk about sudden cardiac arrest risk, and you might want to do a display swap, and we'll get you on your screen.
Yeah, let me see if I can.
It's normally on the top of the, yeah, on the top, you just go to display settings and it'll swap it to the right monitor for you.
Display swap.
So if you go to present mode,
Presenter mode.
and then on the upper part of the screen on the right hand side, second option over, once you get into display mode, you're not there yet.
Let me just see if I disconnect this. That'll help.
Oh, or you can pull the plug. Yes.
Nope. Oh, here. I know how
Okay.
to do it right here.
So up on the top,
Nope.
display settings. No, you were right. You were right.
I was right.
You were right. Go there. Trust me, I've done a couple of these.
Yeah, I know.
You're
you are the queen. Okay, so here.
Up top, all the way to the top, display settings.
Display settings. Sorry, everyone.
A little higher, a little over.
Oh, right here.
There you go.
Gotcha.
And then you click on that
Swap.
and swap.
There we go. You
There
guys see it?
That's it. You're good to go.
All right, great, wonderful. Thank you so much, everybody. It's been really a pleasure to be here so far and a pleasure to speak to you all. Thank you for taking the time out of your day, life, night, and it's really a pleasure to be a part of this teaching summit. I am Jonathan Su. I'm one of the cardiac electrophysiologists at UC San Diego. Let me know if you can't hear me, but hopefully the audio is good.
You're good to go.
Great. Today I'm going to be talking about arrhythmias in hypertrophic cardiomyopathy. Obviously, as a cardiac electrophysiologist, that is my area of expertise. We pride ourselves here at UC San Diego in being not only a center of excellence for hypertrophic cardiomyopathy, but and all types of arrhythmias, but really specializing in arrhythmias specific to hypertrophic cardiomyopathy. And it's really been a pleasure to work with Jorge and Dr. Adler and everybody in the HCMA in regards to awareness and building a center of excellence that really stresses the arrhythmia care of you all in this special population. So I apologize, or don't apologize, if I keep things pretty basic and patient level. I apologize if it's a little bit too basic, but I really want to stress important aspects of arrhythmia care in patients with hypertrophic cardiomyopathy, specific to UCSD, but also just in general care of patients such as yourself. So here are my disclosures. The objectives of my portion of the talk are really fourfold. We've already somewhat defined how common HCM is, but what we really want to talk about are some of the tough aspects of HCM in our discussions with patients, which is really the risk of the elephant in the room, which is sudden cardiac death associated with this disease process. Unfortunately, nobody really loves to talk about how this disease process can take one away or one's loved one away, but it is something that needs to be addressed, and it is a risk of this disease process, and we need to address that, consider it, and make it important in the care of our patients with hypertrophic cardiomyopathy. In light of this, it'll be important to talk a little bit about the historical overview of HCM and some of the reasons from a basic physiology perspective of why patients with HCM have the risk of sudden death. And I think it's important for all of us to realize, patients and clinicians, that there are very important risk factors that predict sudden cardiac death in this important patient population of patients. And then on top of that, we are thankful and lucky and blessed, I think, even in 2020, to highlight technology and devices that have evolved over the years to reduce this unfortunate risk. And it really has been a pleasure to take care of patients such as yourself who may have this disease process and have, unfortunately, this particular risk. So how common is HCM, but not just how common HCM is, but how about this specific risk for sudden cardiac death in HCM? Are we alone out there if one has HCM in regards to this risk of sudden cardiac death? You know, this is one of the seminal review papers in regards to evaluating patients and defining the epidemiology, how common this disease process is across the country and the world. We know about the statistic that really is quoted oftentimes, 1 case in 500 persons. That's over 20 million people worldwide. What I'd like to highlight is really that there's a lot of individuals that aren't on the Zoom that are unidentified with this disease process. And it really is unfortunate when these individuals are discovered in competitive sports, on the wards, in the hospital, when an event has already occurred and there is no knowledge, pre-existing knowledge that a patient has this disease process. And unfortunately, the first manifestation is an arrhythmic or sudden death manifestation. In some ways, we find ourselves to be blessed in the fact that patients do survive some of these events, if not many of these events, and we're able to identify individuals and save their lives as a result of that, and save future lives as a result of that. But it is really an important and something that we take certainly to heart in regards to understanding that there are a large portion of unidentified individuals, and even in patients that are identified, some can be symptomatic and some are asymptomatic. Now, we are familiar with some of the individuals that have been identified with this illness and some of the arrhythmia manifestation of the disease process of hypertrophic cardiomyopathy. Hank Gathers is one certainly that comes to mind and reaches, unfortunately, the headlines in this regard. Nobody really likes to put a spotlight in this manner to really define the disease process based on individuals that really garner media attention or what have you. But what it does, I think, in the care of patients with hypertrophic cardiomyopathy is just give an overall awareness of how this disease can strike individuals that one considers to be very healthy and vibrant, and loved ones and anybody across the world. It is although it is considered a rare disease and arrhythmia manifestations are a rare complication of this disease, the prevalence of these type of disease processes and the arrhythmias are unfortunately frequent enough that they do garner media attention. And we should view this as a way to, I think, solidify our base as far as making sure that we understand this, use it for research, understand the disease process, and really understand what we're dealing with. So when we talk about how arrhythmias are manifested in patients with sudden cardiac death, and understand that really a lot of this garners attention due to the fact that this disease process and arrhythmias are identified in patients that may be athletes. One of the things that we see is that there are several disease processes of the heart that can specifically cause arrhythmia complications. If we take all of those disease processes, particularly in athletes, one thing that we really need to keep in mind is that this disease process that we're here to talk about today, hypertrophic cardiomyopathy, is the most common cause of death in athletes. And if it's the most common cause of death in athletes, obviously that may a little bit be certainly from the obstruction, but that's going to be a lot from, unfortunately, sudden cardiac death from arrhythmias. I think it really shows how important this disease process is to clinicians and cardiovascular professionals, as well as how much attention we need to pay to arrhythmias and this disease process in total, as rare as we may consider it to be. Now, when we talk about hypertrophic cardiomyopathy therapies to reduce the risk for death and sudden cardiac death specifically, thankfully, when we have to talk about this aspect of the disease where we are all trying to avoid it. Unfortunately, it's somewhat like cancer. Nobody really wants to talk about it, but it needs to be talked about. Unfortunately, the death risk associated with hypertrophic cardiomyopathy we know is higher than the general population. Otherwise, we wouldn't be here talking about this today. Thankfully, compared to the early studies of hypertrophic cardiomyopathy, with our current strategies, which involve arrhythmia care devices such as the implantable cardioverter defibrillator and other heart surgery aspects, we have thankfully reduced the risk of morbidity and mortality, death, in regards to the hypertrophic cardiomyopathy population. So our contemporary treatments that include these arrhythmia devices, I would argue, are very important in the care of you all and our patients with hypertrophic cardiomyopathy. So let's go over the historical overview and the reasons why the risk of sudden death exists in this population. Why does it happen? Well, we know just at a basic level that what happens in hypertrophic cardiomyopathy due to mutations in regards to the muscle bundles is that it creates disorganized muscle bundles of the heart. And when disorganized muscle bundles of the heart occur and integrate, it creates a source of a circuit, an abnormal electrical circuit in the heart that can cause the heart to go fast, usually in the form of ventricular tachycardia or ventricular fibrillation. This fast heart rate is not good. It causes a lack of filling and death. And this is what we're trying to avoid when it comes to sudden cardiac death, which is the most common manifestation of arrhythmias in this specific disease population. So when we talk about ventricular arrhythmias, what does it look like or why does it occur? We know that this abnormal septum, the muscle in the septum of the left ventricle or the heart, can occur. This causes scarring. Here's a histology or under the microscope perspective of how that looks. And this type of abnormality causes fast rhythms, electrical fast rhythms that are what we call reentrant or spin around. And this causes the heart to go fast and can cause sudden cardiac death. The historical aspect of this disease process is that, Dr. Murawski, who is one of the pioneers in our fields of arrhythmia, realized that individuals that had this manifestation or arrhythmias, not necessarily only in hypertrophic cardiomyopathy, but actually most commonly initially with one of the most common cardiac conditions, which is coronary artery disease and heart attacks, had the risk of sudden cardiac death as well. And by implanting a device that is able to both sense or detect abnormal rhythms that could cause sudden cardiac death, as well as pace faster than the arrhythmia or shock the heart, defibrillate the heart, in a patient that can have this device potentially for the rest of their life, can be life-saving. And this historical aspect has grown from a large device that sat in the abdomen of a patient and had wires through the vein into the chest, to a device that we now consider to be much smaller, and devices that are completely subcutaneous or under the skin and don't actually touch the heart. Here's a depiction of what we're talking about. Our technology has evolved to the point where we can create a small device that it sits usually in the left upper chest or right upper chest and is connected to wires, a defibrillator, implantable cardioverter defibrillator, or ICD. This device is then connected to wires that traverse the vein in the chest, and the wires go to the heart, screw into the heart muscle, and are able to create an electrical impulse that, if arrhythmia were to be detected, it would be able to attempt to pace the patient out of an arrhythmia in order to avoid a shock, and in the worst case scenario, try to shock the patient out of the heart, which we know can be certainly life-saving. As we saw from the historical context, these devices have evolved from their size and their abilities to reduce the risk of inappropriate shocks that aren't necessary, and increase the amount of appropriate shocks, or shocks that can be life-saving. Not only that, our devices have evolved to the point where now some of them in the right patient population may not even touch the inside of the heart. These subcutaneous implantable cardioverter defibrillators can be implanted now on the side, under the skin and the side aspect of the chest, with the lead tunneled under the skin, but over the chest wall, and can cause and allow the patient to be defibrillated from these abnormal rhythms and their life saved from sudden cardiac death, without the potential risk of the devices that go within the body themselves or within the vein and touch the heart. Some of the seminal work, some of the important studies that have shown that these defibrillators are life-saving, specifically in a hypertrophic cardiomyopathy population, include the one here published in 2007. Now, some of the terminology that we use is called primary prevention and secondary prevention. Primary prevention means that we know a patient has hypertrophic cardiomyopathy and that they are at risk for sudden cardiac death, but have never experienced an abnormal rhythm that could cause that. Secondary prevention means that a patient has the disease process and actually also has had an arrhythmia. What we know then is that obviously those with secondary prevention are going to be higher risk for having another arrhythmia. And therefore, this population certainly is indicated to receive a defibrillator because their risk is so high. And when we implant a device in a secondary prevention population, by 5 years, almost 40% of individuals have had an arrhythmia that could be considered life-threatening and receive a therapy as a result of it. When we talk about a patient population of hypertrophic cardiomyopathy patients, this is all patients with hypertrophic cardiomyopathy, but have risk factors or a risk factor for arrhythmias or sudden cardiac death. This is called primary prevention. We implant devices or ICDs in patients that don't have known arrhythmias or known sudden cardiac death in order to avoid this, because we know, unfortunately, and in those of you that have had loved ones or friends who have died of this disease process, the first manifestation, unfortunately, can be sudden death. In 10% of this population that have hypertrophic cardiomyopathy that have never experienced sudden cardiac death or arrhythmias, their risk of needing therapy or life-saving therapy can be about 10% at about 5 years of follow-up. So knowing that there is this risk that we don't want to talk about, but we need to talk about, who should get an ICD and how do we as clinicians and patients, let's be honest, decide who is at risk and who should get this therapy if it can be life-saving? And that is not an easy question. It is one that thankfully has research behind it in regards to trying to help us determine this. And we know that the ICD is the mainstay of therapy to prevent this, but we also need to determine who should get it. Now, we'll take an easier case of individuals that likely most people would argue should certainly get an implantable cardioverter defibrillator. We talked about secondary prevention and the definition of that in patients who have already died suddenly and then are found to have hypertrophic cardiomyopathy as a result of it, or have had a sustained abnormal rhythm from the bottom chamber of the heart, ventricular tachycardia, for greater than 30 seconds. It is expert opinion and research would indicate that it's certainly appropriate to implant an ICD to prevent future episodes of this down the line. And that rate of appropriate discharge, if one were to implant an ICD in this population, is about 10% use of this per year. So one can see that that risk is quite significant and potentially life-saving. And this is what we're trying to avoid. This rhythm that we see on an EKG is life-threatening and cause people to pass out or pass away suddenly. When it comes to individuals who have hypertrophic cardiomyopathy, but don't have any of these major issues or a previous history of sudden cardiac death or arrhythmias, then we rely on predetermined risk factors based on research and studies that have been shown to be associated with the risk of sudden cardiac death. This is not a one-to-one relationship. This does not mean you definitely will have an abnormal rhythm or definitely will pass from hypertrophic cardiomyopathy, but increases your risk of having that issue down the line. These are the important things that clinicians are going to be paying attention to and you should be aware of. And that, number one, is a family history of sudden cardiac death due to hypertrophic cardiomyopathy in a first-degree relative. Number two, a left ventricular wall thickness of greater than 3 centimeters, so just a thick heart tissue as a result of hypertrophic cardiomyopathy. Unexplained passing out that is likely from the arrhythmia. Number four, non-sustained ventricular tachycardia, so abnormal heart rhythms from the bottom chamber that are shorter than those that can cause sudden cardiac death, but one could prolong and therefore predispose one for sudden cardiac death. Extensive fibrosis or scarring is what one would call this. And this is usually detected by MRI technology imaging that shows that the left ventricle has this what we call enhancement or evidence of scar based on dye or contrast that stains the heart when we do MRI that shows that there is this scar that may predispose to sudden cardiac death. Number six, left ventricular dysfunction, when the heart itself not only is thick, but doesn't pump well with an ejection fraction of less than 50%. And number seven, when there is an apical, which is the kind of the corner of the heart, aneurysm or outpouching of the heart. We know that the rate of discharge for ICD in this primary prevention population is approximately 3 to 4% use per year. So when we make this very challenging decision of who really should get an ICD, it may seem at times that this decision is variable or incorporates a lot of different variables. And that certainly is the case, but I want to stress that a lot of these decisions are made based on previous studies and research. There is amount of certainly clinical judgment. There are a lot of discussions about risks and benefits of our devices. Nothing, unfortunately, has full benefit without some risk. And we are very big on this in the arrhythmia community. Those of us that implant defibrillators or perform arrhythmia type procedures or surgery, a shared decision-making process between doctors and patients. We're here to help you and your loved ones survive and do well with this disease process, and involving you to understand the risks and benefits of any of our procedures is very important to us and should be very important to you. So fortunately, there are these bodies or decision aids that have come about to help patients determine and understand what we're trying to accomplish, the benefits versus the risks, so that you can be involved in the decision making of whether or not an ICD is the right choice for you. And this is a website that is used in a lot of the individuals, not just hypertrophic cardiomyopathy, but patients that are indicated for defibrillator implantation. Now, when we look at some of the data, some of the research, I want to just briefly talk about some of these studies and not go too much into depth that help us determine how much risk. One of these studies that was published in a recent journal article showed a cohort of individuals with hypertrophic cardiomyopathy, over 2,000 individuals over a 16-year span, with ICDs implanted in over 500 patients who have at least one of these risk factors that I talked about. What they showed was that there was a 5-year probability of using the device or appropriate device therapy was over 10%. So we do, unfortunately, hypertrophic cardiomyopathy patients, when you use these risk factors, do have a risk of needing this device in order to save their life. And that estimate of how many devices need to be implanted in order to prevent one sudden death, this is what we call in our speak, doctor speak, as the number needed to treat. Although it may seem high to a patient, 6 ICDs implanted to prevent one sudden death, this is actually considered to be a therapy that would be very worthwhile and very helpful in a patient population. So 6 implanted to save one life. Now, as patients, you out there certainly are and should be considered, and we as clinicians certainly need to consider quality of life. We want you to be happy, even in 2020, obviously, especially with what's going on. And the quality of life is really important no matter what disease process you have, or if you have a disease process. But if you're living with this condition, we want you to have a good quality of life. And we want you to know that by having implantable cardioverter defibrillator, although certainly, this is a procedure and this is a device that will live with you potentially for your entire life, that one can have an important psychological quality of life. This study looked at quality of life in those patients with hypertrophic cardiomyopathy, over 400 patients with high risk features with hypertrophic cardiomyopathy on multiple centers. And at least one appropriate shock was seen in 19% of patients, and the rate of shock was about 4% per year. Despite the need to use this device, what was found was that there was no significant impairment of psychological well-being of the patients or quality of life of the patients, suggesting probably that knowing that these devices, albeit that a shock may be uncomfortable, that can be life-saving, hopefully is saving lives without adversely affecting our patients with hypertrophic cardiomyopathy psychologically and with their mental well-being. Now, we know that these devices are used in other patients with other conditions, including ischemic heart disease or coronary artery disease. And fortunately, these devices appear to be better or more effective and improve how patients do, even compared to that cohort of patients. So thankfully, these devices seem to be well tolerated in a hypertrophic cardiomyopathy patient in general. Now, when we talk to hypertrophic cardiomyopathy patients that get these devices, and they ask us, once I have this device, and is it really lifelong? Do I really need this device for quite some time? And the short answer is, unfortunately, hypertrophic cardiomyopathy is a lifelong disease. One doesn't get rid of hypertrophic cardiomyopathy. We mitigate it. We perform surgeries. We use medications. We implant defibrillators to have people live healthier and happier lives. That being said, the risk of an arrhythmia does exist even out 5 to 9 years and out to greater than 10 years. And therefore, if one does have a risk factor or has died suddenly, then certainly these devices can still be life-saving out past many, many years of knowing one has hypertrophic cardiomyopathy. So one has to take into consideration that aspect of care in patients with hypertrophic cardiomyopathy. Now, I don't want to be so negative in regards to this a sentence, if you will, if someone has hypertrophic cardiomyopathy. I want to be more positive in the aspect that we have therapies that say if someone is receiving a shock that may be uncomfortable from their device, that we do have options for arrhythmias in hypertrophic cardiomyopathy. So if one has an ICD shock, there are other therapies such as ablation, where we weave a catheter through the vein or artery in the leg all the way to the heart to determine where these arrhythmias are coming from, and can potentially ablate or burn heart tissue to prevent these arrhythmias so that the device doesn't have to shock or go off. And so keep that in mind, that this is not a sentence to incessant or multiple shocks, that we have, and we've evolved our therapies within electrophysiology and arrhythmia to improve, hopefully, quality of life in the care of our patients. And that's what we're really seeking, and that's what what motivates us to improve how everyone is doing, including those with devices. Now, I almost paused to not include anything about atrial fibrillation because it is so much to talk about sudden cardiac death and defibrillators in hypertrophic cardiomyopathy. But I thought I would be remiss not to talk about this other type of arrhythmia, which you're going to hear about in patients with hypertrophic cardiomyopathy. Why? Because you're going to hear about it in loved ones that don't have hypertrophic cardiomyopathy, because it is a very common arrhythmia, and it's even more common in hypertrophic cardiomyopathy. In general, atrial fibrillation is an irregular rhythm of the top chambers of the heart, the atrium. This is different than what's most commonly affected in hypertrophic cardiomyopathy, the ventricle. But there certainly is interplay with these disease process. AFib in general, it afflicts 1 in 4 Americans over the age 40, and certainly a higher risk in patients with hypertrophic cardiomyopathy, which is why this disease process is important. When we talk about management of atrial fibrillation in patients with hypertrophic cardiomyopathy or without, in just patients that have AFib, there's 2 pillars of management. One is whether we're going to control the rate or rhythm, and the other is stroke risk reduction. And we know stroke is important in hypertrophic cardiomyopathy patients that have AFib specifically. And it's just really important that one thinks about this and knows about this. I'm not going to go too much in depth. Happy to take questions, but also know that we have therapies to reduce stroke risk in AFib and reduce symptoms in AFib and improve how patients do quality of life wise. One of the ways we do this is a different type of ablation procedure where we weave catheters through the veins in the leg all the way to the heart, to the atrium, and try to ablate or burn heart tissue to prevent atrial fibrillation. This certainly has become more common in hypertrophic cardiomyopathy. You're going to be hearing about it more in general, and hopefully we can improve the quality of life of our patients, including those with atrial fibrillation and hypertrophic cardiomyopathy. So with that, in summary and take-home messages, I just want to say that sudden cardiac death, even though it's very challenging to talk about and difficult to talk about, including in consultation with our patients, is a very important concept in our hypertrophic cardiomyopathy population. ICDs are highly effective to prevent sudden cardiac death, and should be a discussion one you have with your clinician in regards to whether or not you qualify and should consider this. Risk factors are helpful in determining who should get one and who should be considered to have one. And obviously, discussions with your clinician and clinical judgment, including that shared decision-making process with you, the most important person of this decision-making process, the patient, need to be done and are very important for your care. So with that, I really appreciate your time and attention, and happy to answer any questions, and feel free to contact me or add me on Twitter and have that discussion.
Thank you so much. Excuse me. We do have a couple of questions, and I'd like you to address something before we even get off to the next talk.
Sure.
Sadly, over the past couple of months, we have lost a number of community members because they don't feel sick, but are told that they're at high risk for an arrhythmia. And because they don't feel ill, they think they're not at risk. Could you please address the difference between being high risk of sudden death and being symptomatic, and how they are not always correlated?
Yes. Certainly when we talk about some of the risk factors for sudden cardiac death, let's just put the elephant out in the room, out there. It doesn't necessarily have to do, not all the risk factors, the 7 risk factors, have to do anything with symptoms. Some of them are symptoms and some of them are not. And if we think about the disease process in general and how many people manifest it, they either die suddenly and then it's discovered in a loved one, or they die suddenly and they make it thankfully to the hospital and the disease process is discovered. In some of those circumstances, we are lucky. We have, in 2020, although it's a tough year, we have technology, AEDs, ways to detect this, way to save people's lives that help us discover this disease process. So you can imagine, or incidental imaging or other ways where this disease process never would have been discovered in historical times. So in some ways, we are becoming more lucky, more able to identify this, more aware, and it increases the population of people who are going to be identified this and at risk and could potentially be saved by these devices if one is able to identify and do that early. So it is important to realize that a lot in some of these risk factors have nothing to do with symptoms and have been well established, and certain things seen on imaging or on arrhythmia monitoring, which may not be associated with symptoms, can be pretty clearly associated with the risk of sudden death. So when your physician tells you that, hey, we're picking up these things and the data suggests that it would be associated with the risk, I think you really do have to take that into account, even if you feel well, because we know, unfortunately, that this may be the first manifestation in a patient with hypertrophic cardiomyopathy.
Yeah, I would agree. I would just say, it's the hardest thing we do is trying to predict who's going to have a sudden death. And unfortunately, the first symptom of sudden death is death sometimes. So it's hard for us. And, I think defibrillators are not completely benign. And John knows that. I've had patients come to me and want their defibrillators removed. But I've had many more patients whose lives have been saved by them. And so it's not an easy decision. I understand that. It's one of the hardest things I struggle with. And I'm lucky to have John and Jorge. And I think the best way is it's shared decision-making. One of the unique things about a center of excellence like ours is that we can come together as a group and discuss our patients together. And so try to put our heads into it and then bring the best information to our patients. But it's an evolving, I think the risk tools we have are good, but not great, to be honest. I think they're very good, but I think we can do better in how we predict. And that's an area of research that we're really interested in. But you can't be wrong, So it's a really frightening thing that about this disease. And I've been really scarred by it multiple times. And patients family members. And so we take that very seriously. But anyways, I know that we're a little bit behind time here, right? So
let's catch up. Okay, so we'll hold the rest of the questions until the end. And next up, we have you. So Dr. Adler's going to talk to us about transplantation, as I like to say, near and dear to my heart.
That's right. So let me just get here we go. So let's talk about heart transplant now, and heart transplant as it's relevant to hypertrophic cardiomyopathy. Here's some of my disclosures. So I want to talk about a couple cases. This is a 45-year-old vegetarian, healthy patient, never smoked or drank in his life, a very stressful job. He was at this outside hospital facility because his friends and family noted he was just depressed, fatigued, not participating. He had this weird shoulder pain. I saw him, he appeared older than his age, and he was big. He was 400 pounds. He's a real heavy obese guy. You might call him obese. Couldn't see his neck very well, and he had elevated biomarkers by BNP and troponin. And his echo, you can see he had hypertrophic cardiomyopathy in the end, and it took several different opinions before he came to me, and we diagnosed him with that, and we put him on beta blockers, and he remarkably felt better, and I've been following since. And the interesting thing about this patient is he's actually a gorilla. So he was a gorilla at the San Diego Zoo that had hypertrophic cardiomyopathy that we were consulted on. And as a good mentor and program director of our heart failure program, I made sure our fellow here on the left did the actual TE on did the procedure on the patient. I was far away from this 400-pound gorilla. At the very end, I got a nice shot of me listening to his heart, trying to elicit a hypertrophic cardiomyopathy murmur. But the gorilla had hypertrophic cardiomyopathy, which is a surprise to me, but that has been described rarely in the past. This is a silverback gorilla who is a very special gorilla because has 7 or 8 wives, and so that was his very stressful job. And thankfully now he's doing quite well. So here's another patient with hypertrophic cardiomyopathy that didn't respond as well to medical therapy. This is a woman who lived in Wisconsin, came to us as a second opinion. She had a myomectomy. 8 years later, now her ejection fraction had dropped down to 30. She had moderate mitral valve regurgitation, so she had a leaky mitral valve. She's class 3 symptoms, so that means she was short of breath with even mild exertion, just doing routine activities. And she was on home dobutamine, so she was getting a medicine through her veins to help her heart function. And she's referred to us for heart transplantation. And she was noted to have lots of antibodies in her blood, and we'll talk about that, which made transplant very difficult. And that's how she was sent from Wisconsin specifically to UCSD, where we do specialized and high-risk heart transplant. And I'll talk about her more throughout this talk. So heart transplant's been going on since 1967, over 50 years, 53 years. And the miracle of transplant, one of the things that's a miracle to me about it is it really hasn't changed a ton in this 50-year period. It's gotten a lot better, but the fundamental idea of heart transplant has remained the same. We do now roughly around 2,000 heart transplants in the United States annually, and 90% of our patients live greater than a year. We also are doing more and more mechanical hearts annually. That includes ventricular assist devices, which I'll talk about, and even total artificial hearts, all potential options for hypertrophic cardiomyopathy patients. Not as much ventricular assist devices as heart transplant, but I'll talk about that in a bit. So who should get a heart transplant? These are people who are with really end-stage heart failure. That's the most common thing, or very symptomatic heart disease, as well as patients with hypertrophic or restrictive cardiomyopathies and have refractory symptoms. Patients with really bad arrhythmias sometimes get heart transplant, and patients with broken mechanical hearts. Very rarely we do heart transplant for people with tumors, and sometimes we do a heart transplant for patients with congenital heart disease. What about specifically heart transplant in patients who have hypertrophic cardiomyopathy? It's generally reserved for those with refractory symptoms. So obviously in patients who have already tried drugs, have already maybe tried myomectomy, ablations, septal ablations, whatever it may be, and are still having symptoms. There's risk with transplants, so we just don't do it for everybody. And there's only a certain number of people. Can you imagine there's only 2,000 transplants done in the country? So it's not available to everybody. Usually we see the patients are with hypertrophic cardiomyopathy in particular who are getting transplanted are starting to develop symptoms of heart failure, can't exert themselves, can't participate in activities of daily living. The one thing to keep in mind, and this is some doctor speak here, but we don't necessarily one of the things that fakes out doctors who are not familiar with hypertrophic cardiomyopathy is these patients may on paper look better than a typical heart failure patient looking for transplant. In other words, this is VO2 here, but in other words, their exercise tolerance may be a little bit better than what we normally see in a heart failure patient. Their EFs are not always as low as in a heart failure patients. So that sometimes they go to see a heart failure doctor, go to their cardiologist, and the cardiologist says, oh, you're too well for a heart transplant. And that may not be the case. The quality of life of patients with hypertrophic cardiomyopathy as it gets to end stage, and when they're getting the severe chest pain with hypertrophic cardiomyopathy, the severe arrhythmias, the severe fatigue and shortness of breath may be as bad, if not worse, than some of our end stage heart failure patients, but it's just under recognized. And I'm sure Lisa's and many of the members of HCMA community can attest to that. The EF can be preserved or low, as I mentioned. And the other thing that's very important is that the outcomes, both while on the wait list and after transplant, seem to be identical. So patients who have hypertrophic cardiomyopathy and need heart transplant do as well as those with other diseases that need heart transplant. There's a fancy status listing system that we use to decide who needs a heart transplant and what order. And this is a lot of doctor speak, but the bottom line is that in 2018, an improvement occurred where patients with hypertrophic cardiomyopathy got bumped up. They used to be sitting in the lowest tier, and now they're in status 4 just for having hypertrophic cardiomyopathy. So that gives them a better chance of getting transplanted sooner than it used to be. One of the things about heart transplant, it's not a cure for everything. And sometimes it's frustrating for patients who are like, I know I need a heart transplant. Why aren't I a candidate? When we look at patients for heart transplant, we're patching holes in the boat. We're not fixing everything, and we have to think about everything. So what are the psychosocial support factors that this patient with a heart transplant has that's going to get them through the heart transplant? What other medical conditions do they have? Do they have diabetes? Do they have arthritis? Do they have other things that might impair their ability to recover after heart transplant? It's a big surgery. And economic factors, are they going to be able to afford their drugs? Are they going to be able to come to their appointments? All these things, unfortunately, we think about when we're looking at heart transplant. I mentioned the patient had antibodies, and what was I talking about? Well, all of us make antibodies in our blood to fight infection, but some of us have antibodies which exist, which also may cross-react with a donor heart at the time of transplant. So this is more common in women, and it's more common in people that get surgery, like myomectomies. So before a heart transplant, we look in everyone's blood to see if they have antibodies. And in this case, this woman had, unfortunately, a lot of antibodies, which made it hard to find a heart that would be a good match. And many of you remember from the lay press this idea of like, we have to find a heart that's a good match. So we did special procedures on this unfortunate patient. We did a procedure called plasmapheresis, where we removed the antibodies from the blood, and then we gave her special medications to reduce the amount of antibodies in her blood. And we reduced the amount of antibodies in blood to much lower amounts. She ultimately underwent heart transplant after 110 days on our transplant list. And she, after transplant, received an experimental drug that's only available in a few places like UCSD to make sure she didn't reject. And now she's doing great, and she's moving back home to Wisconsin. So it's a really great story of a woman that's had hypertrophic cardiomyopathy that went on to get heart transplant. What does heart transplant look like? Well, I always joke this is the easy part because I don't do it, but in reality, I give a lot of credit to our surgeon, who also is our primary myomectomy surgeon, one of our primary myomectomy surgeons, Victor Pretorius, who does most of our heart transplants. And you can see it's a process most of the time now where we keep some of the heart of the donor, of the recipient, and the veins and arteries of the recipients, and we hook up and suture in the new heart. And I say we, I mean the surgeons. I'm not a surgeon. Hook up the new heart to the old heart. So you keep some of the old heart, you suture together some of the main veins and arteries in the heart, and then this is what it looks like. This is the modern technique, which is called a bicaval technique. And this is actually associated with very low rates of arrhythmia. We use a lot of meds after heart transplant. We always say heart transplant is not a cure, it's a trade-off. So people have to understand that they're going to be on steroids for a period of time and some medications for the rest of their life, and those medications can have side effects. So that's why we reserve heart transplant for the sickest patients, because we know we're trading one set of medications for another. We're trading one set of side effects for the other, and we're trading risk. You know, there's risk of transplant, so we're trading that risk. So that's why we only reserve transplant for the sickest patients. We are through this third era of transplant. This third era is, oh, my slide is broken. It's this gentleman who's 23 years out after heart transplant. The first era was just, could we get people off of the table? The second era was, could we keep people alive for a year after transplant? Now our goal is to get patients alive 20, 30, maybe 40 years after transplant. We have a patient now who's 35 years after transplant doing well. So that's our goal. It's important when we're transplanting people in their 30s and 40s that we can offer them 30 or 40 more years and really extend their life to a normal lifespan. We do a lot of advanced procedures here at UCSD, and I'm just going to spend the last 5 minutes talking about it. We do heart transplant, heart lung, heart kidney, heart liver. So we're the only place in San Diego that does all of these procedures. We do lots of mechanical hearts and ventricular assist devices, biventricular assist devices, total artificial hearts, ECMO. Basically, we're a one-stop shop for all of the advanced cardiac surgeries you can think of. And we do a lot. And last year we did 70 heart transplants, and this year we've already done, if we haven't already done it, we're very close to doing 70 heart transplants already. So lots of heart transplants here, and our outcomes are very good. This is a ranking of all the heart transplant programs in the United States, and the lower you are, the better. And this is us, UCSD. So we were the best out. This is in 2019-20. We were the best outcomes in the United States for heart transplant. And in fact, on my table, I brought it for you guys. This is a little award we got from Interlink, which is a certifying network, and they certified UCSD as the best heart transplant outcomes in the United States in 2020. So we're really proud of that. And our patients are happy. When we ask them, they all say they're very happy, and they always talk to us like we are part of the family, and that's how we want it to feel. And I'm sure Lisa's part of her family, her program, and it becomes this really amazing support group here. As a test of that, one of our patients, I don't know, Lisa, if you did this, but one of our patients actually tattooed on her back Dr. Pretorius's signature. So that's actually, it was the spouse of the patient that got the heart transplant. So I thought that was a pretty impressive thing to do. But the list keeps growing. We need more hearts. So we need to do innovative things to get people more hearts. And so what are we doing here? In this case, this is one case where we gave one heart first to one patient, and that patient unfortunately expired suddenly, and it got passed on to a second patient. So this one heart was in 3 patients. That's only been done 8 or 9 times ever. So this is a very rare disease, but this is a very procedure that we did here to kind of save a heart. The other thing, which is super exciting, I hope this plays, it does. So we are now doing something called Heart in a Box. So what this is for us to be able to preserve hearts and get as many hearts as possible, we actually take a heart and we can put it in this special machine and resuscitate the heart. So if the heart does not look good, or even if it's dead, we can take it out, we put it in this machine and resuscitate it. We can travel, believe it or not, the highest are like 18 or 20 hours, but now we can travel 5 or 6 hours with this heart in this machine that provides the blood from the donor. So it's like it's living in the donor, but it's in a box now. So this is a game changer. There's only 6 or 7 places in the United States that have this. We're the only place that has this right now, west of Chicago, or west of Wisconsin. So we're really, it's made it so our wait list times are much shorter because there's many more hearts available. This is called Deceased Donor After Cardiac Death program, and we're proud to have that here. We offer biventricular assist devices for people sometimes waiting for transplant. I will say we seldom use LVADs in hypertrophic cardiomyopathy patients, but occasionally we have to do that, or a total artificial heart for patients when their hearts are so bad and both sides of the heart are weak. And so we've done that several times for patients. We've made some changes since COVID. So how can you not talk about COVID in 2020? We kept going. We kept doing our heart transplants, but we've done everything we can to make it safe. You know, we're all in different rooms. We don't even have meetings in the same room together because we don't want to affect our whole team if one of us got sick. We're not, you know, we're limiting our number of visitors, which is hard, but we are continuing to do heart transplant because we feel like it's life-saving, so we didn't want to stop it. And we've done close to 40 transplants since March. We've never had a patient get COVID in the hospital. We had one LVAD patient die from COVID, unfortunately, and we've had one patient after transplant who died, and the caregiver couldn't visit the patient, so that was very hard. But generally, we're doing quite well even, and we've changed our policy subsequently, and now we can have caregivers visit. But so we've done well despite COVID. So here's a picture of our team. It's actually, this is a outdated photo. I got to get a new one. It's a bit, but we've got a big team. I think heart transplant is a kind of an option that we save when we've used everything else, but it's a very good option. It shouldn't depress you if it's time for transplant. It's just closing one door and opening another. And we've had our patients do really well. And patients have a high survival across the spectrum of risk, and we do specifically UCSD, we do a great job, and we'd love to help you. And here's our team in a more casual setting. So,
and that was a pre-COVID picture.
Definitely, yeah, that was very pre-COVID.
So before we transition to the next talk, I do want to bring up a couple of points about transplant that I think are pretty cool in terms of HCM. The first patient ever diagnosed with HCM, Claude Brady, who was diagnosed on September 18th, 1959, transplanted in 1988. And for anybody who watched the patient-focused drug development meeting, he was my special guest at the break. And he is 30 years out. He's 88 years old. And I'm sorry, 83 yeyears old. And I had dinner with him in June during COVID and distanced and safe. But he's still doing well today, and we'll share his story more. And then another really cool HCM connection. The first, and I'm going to have you explain this kind of deceased donor. The first deceased donor woman in New York City was an HCM patient. She lives here in New Jersey, and she got her organ, I believe it was February or March of this year.
Oh, wow.
And that was an in-hospital deceased donor. Can you explain that new process?
Sure. And we're just starting that here. That was probably at NYU, I imagine. Yeah. So this process is where they bring the donor usually in the same hospital. They'll move the donor to the recipient. And in this case, the donor is not brain dead, but the heart, they withdraw care and the heart actually stops. And when the heart stops, the heart stops for 30 seconds to 5 minutes. And then once it stops, they resuscitate the heart, but they do it in a way that there's no blood flow to the brain. So the patient has died, the heart has died, and then they resuscitate just the heart in the body, and then they put it in the new body. So it's a way of using more hearts that would otherwise be basically thrown away. And it's similar to the heart in the box, but they're actually doing it in the actual patient themselves as opposed to in the box. And it's a real innovative technique as well, and it's going to save more lives. So we're really excited about it.
I was really surprised because I knew she had gotten her organ and she was doing really well post-transplant. And I was really surprised how fast she got out of the hospital and that the heart wasn't stunned at all. And then I found out 2 months later that she was the first deceased donor recipient in New York City.
Absolutely.
And I'm like, okay, that kind of explains the quick recovery too. You know, the heart wasn't stunned at all.
It is a little weird, you know, that heart in the box, we can now show it to the patients before they get it. It's like you can wheel it over to them and they can look at it. It's like going to like a steak restaurant where they show you the steak before. So
I would have loved that.
Yeah. You can pick it out, you know. So
that's really cool. That's really cool. Okay, so we're going to talk a little bit more about this later. And we're now going to hear from Gabrielle Vaughn, who's going to talk to us about pediatric HCM. And when I come back, it may be a little Halloween-y around here. I'm not sure. Off to you, Gabrielle. You want to do your screen share?
Yep.
There we go.
Great. How does that look?
Fantastic.
Okay. Hi, everyone. My name is Gabe Vaughn. I'm one of the pediatric cardiologists at Rady Children's Hospital, and I work in close collaboration with my colleagues at UCSD. I have no disclosures, but I do want to say a big thank you to Lisa and the HCMA for inviting me to speak tonight. I really applaud your efforts at bringing awareness to this disease. And I really think that this organization has been a valuable resource for my families when we're making this diagnosis in a very young patient. It's important for our patient and families to know that there's a whole community out there supporting them when they receive this diagnosis. So thank you. As I said, I work at Rady Children's Hospital. We are the largest children's hospital in California based on admissions. And last year we did over 28,000 outpatient visits at our cardiology clinics. And we've been ranked in all 10 specialties by US News and World Reports. So the objectives for tonight's talk is number one, children are not just little adults, especially in the case of hypertrophic cardiomyopathy. Children have a very diverse clinical presentation, etiology, and course that differs from their adult counterparts. And I hope to touch on some of the aspects that makes taking care of children with HCM unique and exciting. So we'll talk about the causes of childhood HCM, presentation and diagnostic tools in the pediatric cardiology office, outcomes and survival, management, and sudden cardiac death. It's a lot to cover, so I'll try to keep it brief as some of my colleagues have already discussed some of the important points. So the hallmark of HCM is increased LV wall thickening without an identifiable cause that has an impact usually on normal cardiac performance, whether that's the development of outflow tract obstruction, diastolic dysfunction, or stiffness to the heart, mitral regurgitation, arrhythmias, congestive heart failure, or sudden cardiac death. The disease course is highly variable, and there's no one-size-fits-all approach to this disease, and that's especially true in children. And I wanted to touch a little bit on some important definitions because this really does come into play when we're talking about children with hypertrophic cardiomyopathy. And Lisa mentioned this also at the introduction. When we're talking about HCM, we're typically referring to sarcomeric HCM, which is caused by a mutation in the sarcomeric proteins of the heart. But there's also a subset of patients who are identified as having phenocopies, which means that their cardiac findings are very similar to patients with sarcomeric HCM, but they have different causes for their HCM. And this may be inborn errors of metabolism, congenital malformation syndromes, mitochondrial disorders, or neuromuscular disease. And it's really important to understand the spectrum of these disorders and the natural history for the management of children with HCM. And it really does provide a framework for discussion with families. So there have been large epidemiologic studies looking at the causes of HCM in childhood. And one of the North American studies was the Pediatric Cardiomyopathy Registry, also known as the PCMR. And they looked at all causes of childhood hypertrophic cardiomyopathy. And for the most part, children have sarcomeric mutations or idiopathic hypertrophic cardiomyopathy if they don't identify the gene. But about a quarter of patients with our children with HCM have other causes for their hypertrophy. And it breaks down to almost equal parts neuromuscular inborn errors of metabolism and malformation syndrome in all comers. The infants play a little bit differently in hypertrophic cardiomyopathy. In their cases, it's about 15% each of inborn errors of metabolism or malformation syndromes, and about 70% of the HCM. And so an important aspect of evaluation when a child is newly diagnosed with hypertrophic cardiomyopathy in the pediatric office is also trying to identify, are they a true sarcomeric HCM, or do they have a phenocopy or another cause for their hypertrophic cardiomyopathy? And why this is important is because we need to get these patients established with their appropriate specialist to help monitor and manage the extracardiac manifestations of the disease. And while the approach to therapy is often the same between sarcomeric HCM and the phenocopies, there are some important differences in some cases of treatment, and especially in the outcomes. Prevalence of HCM in childhood is probably largely underestimated. Many children, the majority of children, do not have symptoms, and they likely have subclinical disease and don't come to attention or care in childhood. Right now, the report is about 2.9 in 100,000 children, so much, much lower than what's reported in the adults of 1 in 200 or 1 in 500 adults have HCM. And this does come into play later on, as I'll talk, that we just don't have the numbers to help us with risk stratification in these patients, because we're basing a lot of our decisions on small case series or case reports. So we see children of all ages with this disease, and you'll notice that a large portion are actually infants. So about 23% of patients are diagnosed in infancy, and that's defined as those who are less than 1 year of age. About 46% will be diagnosed in that pre-adolescent or young childhood, so ages 1 to 12, and then about 31% of children present during the adolescent years. So as I said, most children are asymptomatic. Probably up to about 75% of kids with hypertrophic cardiomyopathy don't have any symptoms at all. And so how are they coming to presentation or care? So in the asymptomatic patient, if they have an astute and very good pediatrician, they may detect a murmur on their well child exam. And if they identify that it's a pathologic murmur, hopefully they will make the referral over to pediatric cardiology for some further investigation and testing. There's a small portion who are also presenting for family screening. And then some patients get EKGs for screening purposes, and it may become abnormal, and then they get referred to CS in cardiology clinic. For those who are symptomatic, infants typically will present with heart failure symptoms, which is poor feeding and growth. So an infant with failure to thrive, hypertrophic cardiomyopathy should be on the differential for those patients. And then as you can see, children over 1 year can have a long list of symptoms that are very nonspecific. And so obviously a 2 or a 3-year-old with abdominal pain, unfortunately hypertrophic cardiomyopathy is probably not at the top of the pediatrician's list, but it can present in a number of ways, and that could be abdominal pain, low appetite, shortness of breath with activity, chest pains, palpitations, fainting or nearly fainting. And then of course the big thing is that it's HCM is the most common cause of sudden cardiac death in the young athletic individual, and accounts for about 1/3 of sudden cardiac death cases. So obviously we hope that we identify these patients before this event, but we're not always so lucky. And you can also imagine that young kids, it's sometimes hard to tell if they're having symptoms. It might be difficult to tell if a 2-year-old's short of breath with activity. They don't always have the ability to tell you that they're having chest pains or that they're experiencing palpitations as well. So when they do make it to the pediatric cardiology office, diagnostic testing in children suspected to have HCM, one is mainly to establish the diagnosis, 2, identify LVOT obstruction or regurgitation of their mitral valve, 3, assess heart function. 4, assess the risk of a sudden cardiac death. And then also we should be offering genetic testing and family screening to those who are interested. In the clinic, we always start with a thorough history and physical examination. We pay a lot of attention to the family history as well. All of our patients at the time of diagnosis and at routine follow-up get EKGs. And although EKG abnormalities are not necessarily specific to HCM, they do have typical findings often with prominent voltages of the left heart and repolarization abnormalities. We offer and we perform ambulatory EKG monitoring at all of visits at least once a year. And then we have had a couple of cases where we've collaborated with our EP colleagues to place implantable loop recorders in some of our pediatric patients when it's hard for us to reliably pick up when they're experiencing symptoms and we haven't been able to capture anything on a monitor. We're mostly reserving this for our older kids who can do it with just local pain control. There are a couple of cases, though, where the EKG is pathognomonic for some of those phenocopies. This is the EKG of an infant who was admitted to the hospital with low tone and a failure to thrive, and was getting an extensive workup and was going to have a G-tube placed and her abdominal film. Luckily, someone noticed that there was some cardiomegaly and performed a full chest x-ray, which confirmed it. And then she got this EKG and consulted us in cardiology. And she ended up having an infantile form of Pompei's disease. And so we were able to get our metabolics colleagues involved very quickly. She received her enzyme replacement therapy and the hypertrophy regressed, and she's doing very well from a cardiac perspective now. A comprehensive echo is performed on all of our patients with HCM. We are pretty good at getting good studies on most of our kids. I will say sometimes it's challenging in the 1 to 3 year age group. Toddlers aren't always the most compliant, but we have excellent technicians here who are able to work with our kids, and for the most part are able to get all of the images to help us confirm the diagnosis, and then also help us identify the presence of any outflow tract obstruction, evaluate the mitral valve in detail, and look for any presence of mitral regurgitation. They can usually get us good pictures of the systolic and diastolic function as well. About 20 to 50% of children with HCM will have LVOT obstruction. And then in kids, we do diagnose them with HCM a little bit differently than adults. It's not based on an absolute measurement for the ventricular wall thickness, but we standardize our measurements based on the age of the child and the body surface area. And then we use a Z-score or a statistical method to determine if they are outside of the normal range. So if their wall thickness is a Z-score of greater than 2, then that we can then give them a diagnosis of hypertrophic cardiomyopathy. For those patients who do not have LVOT at rest and are able to perform an exercise test, we can also perform a stress echo here to see if they have inducible LVOT obstruction. We offer genetic testing to our patients, and we do often refer them to our genetics colleagues for help. In the genetics clinic, they can help us if for testing of sarcomeric mutations, but it's also important, as I mentioned, those phenocopies. If there's a suspicion for a condition that mimics HCM, they can tailor the testing based on their clinical exam and findings and help us to come up with a diagnosis for the family. In pediatrics, for the sarcomeric mutations, we identify the mutation about half of the time in sporadic cases and 2/3 of the time in familial cases. And for the 30 to 40% that we do not identify a mutation, we counsel them that science is just not caught up yet, and we likely haven't discovered their mutation. We don't rely on genetic testing right now to aid with prognosis yet, but it can aid us with testing of the family members, we do perform cascade testing here. Something that's unique to Rady Children's Hospital is we have a very robust genomic institute, and they've been extremely helpful in certain cases that we've had for infants who present to the hospital with severe cardiomyopathy. We can get them involved, and we can have rapid or ultra rapid whole genome sequencing. Ultra rapid, we can have our results back within a few days. So this has been very helpful for our infants who are presenting with cardiomyopathy, including our hypertrophic cardiomyopathy. And then we also have had some large families here with multiple members affected by hypertrophic cardiomyopathy, and they've been very helpful in, one, getting them tested and then performing cascade testing on a whole bunch of members of our community who are part of these families. So it's been very helpful. We also perform exercise testing here and stress echoes, as I mentioned. We can generally perform a stress test in children around age 8 years old, but part of being in clinic is we assess their size and whether or not we think they're going to be able to reliably perform an exercise stress test if they have the maturity and they don't have significant delays that would impair their ability to perform the test. And then finally, this is a picture of one of our kid-friendly MRIs here. We've started using MRI on a more regular basis, and we can generally obtain a non-sedated MRI starting at around age 8 to 10 years old. But compliance is variable. I've had 6 and 7-year-olds who can do the MRI with the movie goggles and the headphones on, and then I've had 16-year-olds who can't do the MRI because of claustrophobia. So we do start assessing their ability to do an MRI around age 8 to 10 years old and see if they can comply. If we feel that it's really is going to be helpful to us, we can also employ our child life to go down with the patient, and they've been very successful at allowing us to get the imaging information that we need. In comparison to echo, MRI does have the capability of obtaining higher resolution images, better measurements of wall thickness, and detection of localized hypertrophy. And then also the degree of myocardial scarring, as evidenced by late gadolinium enhancement, has emerged as a risk factor in adults for ventricular arrhythmias and adverse outcomes. And we do have the ability in pediatrics to also assess for the percent of LGE in patients. So once we've established the diagnosis and completed all of our testing, we can begin to counsel families on outcomes, prognosis, and management. And this is often a big question for families. How is my child going to do once they receive this diagnosis? And for the most part, children with HCM have a very good prognosis, but I qualify that by saying the age and the cause has a significant impact on survival. If you take all patients with all children, the freedom from death or transplantation is about 90% at 5 years, and the annual HCM-related mortality is close to 1% in the non-syndromic patients. So as I said, HCMs in children has a diverse disorder, and outcomes depend largely on cause and age. And I think what you'll find really striking on the survival curve is that the infants have the worst survival of all of our patients in childhood with HCM. When looking at a survival curve, what we want to see is a straight line across that 100, meaning 100% survival. But you can see in that solid line for our children less than 1 year of age, they have a dramatic decline in their survival, especially in that first year. And this was obtained through the PCMR. And so they broke out into the different causes of HCM, and you can see that the infants who are diagnosed with an inborn error of metabolism and a malformation syndrome have the worst outcomes with the diagnosis of hypertrophic cardiomyopathy. And in these cases, death is more commonly due to heart failure or non-cardiac causes. But interestingly, infants diagnosed with idiopathic or sarcomeric hypertrophic cardiomyopathy also have a worse survival if they're diagnosed under 1 year of age. However, if they survive to 1 year and older, they have much improved survival with an annual mortality rate of about 1% per year. And the reason for this isn't completely understood. However, it may be a surrogate marker for disease severity. And then the PCMR did a follow-up study a few years later to report on trying to find patient factors at the time of diagnosis that would predict subsequent risk of death or transplantation. And I'm going to get into sudden cardiac death here in a few minutes, but this is different. So they divided the patients up into 6 subgroups: malformation, inborn errors, hypertrophs less than 1 year, diagnosed over a year, and they tried to identify risk factors at the time of diagnosis. And they identified risk factors specific to the subgroup, but in general, if you were diagnosed at a young age, you were underweight at the time, had congestive heart failure symptoms, had a higher thickness to the heart or a lower fractional shortening, so worse function, those usually conferred more risk and worse outcomes. And so knowing this, you can help guide your clinical decision-making and discussions of prognosis with the family. Management in a child with HCM really requires a team approach. So here we have a cardiomyopathy team that includes MDs and NPs. We work extremely closely with our EP colleagues, our cardiac imaging specialists. As I mentioned, genetics and genomics are part of our care as well. For those who are having a hard time with their new diagnosis, we involve social work to help with counseling. Nutrition is really important, and then establishing subspecialty care when indicated. Most often we collaborate with our metabolic, genetics, and neuromuscular colleagues. And then we collaborate a lot with our adult colleagues at UCSD. I'm just going to spend a brief time on this because this was discussed earlier, but I've just gone through saying how kids are different in hypertrophic cardiomyopathy, but when it comes to management, it's actually quite similar to the adults at the current time. So management's really broken up into 2 categories: symptom improvement and prolonging the survival of the child. So in general, if children with hypertrophic cardiomyopathy don't have any symptoms, they have no LVOT obstruction, no evidence of arrhythmias, they do not require any pharmacologic therapy. And so medications are really reserved for patients who are symptomatic. And for us, our first-line therapy is beta blockers. And then if they don't improve, or we're not seeing a reduction in their LVOT obstruction, then we move on to calcium channel blockers. I qualify that, though we don't generally use verapamil in under 1 year of age. There's been reports of apnea and cardiac arrest with that medication, so we reserve that for the older kids. For not getting a good effect on either of those, then we'll try combination therapy. And then finally, we'll move on to non-pharmacologic options of surgical myectomy and heart transplantation, which have been discussed in other talks this evening. So sudden cardiac death risk assessment is always an important part of our evaluation every time we come across our patient. And in our older adolescents, young adults, we can generally apply the guidelines for sudden cardiac death and ICD placement, which has already been nicely discussed. But young children and pre-adolescents, the evidence of sudden cardiac death risk is really not as robust as adult data. And it's really challenging to identify children who are at high risk for sudden cardiac death. As I mentioned earlier, the prevalence of this disease for us is quite low. So we're limited by low numbers of patients. And so mainly risk stratification has been extrapolated from adult data, but some studies have even found that the likelihood of arrhythmic events in children are poorly related to the classic risk factors that we have for adults. So we certainly know that there's a subgroup of children who are at high risk for sudden cardiac death. And it's, difficult for us to really pin down what the risk factors are. We currently estimate that sudden cardiac death occurs in childhood hypertrophic cardiomyopathy. The range is reported between 1% and 7%, although it's probably closer to 1%. And while we have a number of publications that have tried to identify specific risk factors, we still don't have a general consensus yet for risk stratification in this age group. One of the more recent analyses came from Europe. There was a large meta-analysis from 2017 looking for risk factors in patients less than 18 years of age. And they evaluated 25 studies and about 3,000 patients were included in this. And the major risk factor was a previous cardiac event, non-sustained VT, unexplained syncope, and extreme LVH. These were the risk factors that had some statistical significance. but there was not sufficient data to substantiate numerous other minor risk factors. So family history was unsubstantiated, LVOT obstruction, abnormal blood pressure response. So we still don't quite know, and certainly more investigations are needed, whether genetics and cardiac MRI are going to help with children as well. A group from Italy, for example, found that troponin I and troponin T mutations conferred a higher risk for an arrhythmic event. The presence of LGE in kids does appear to be associated with a greater risk of malignant arrhythmias and adverse outcomes, but these are mainly based on reports of small groups of patients. There's 38 patients in a study from sick kids, 30 from Michigan, and 71 patients from Beijing. And so really what we need is multi-center studies to evaluate LGE in relation to outcomes in a large cohort of pediatric patients. And that usually takes us some time to get that work done. So ICDs are effective in aborting malignant arrhythmias. We know that it works in children with HCM as well. But the recommendations in children are similar to adults, but the supporting evidence is not as solid. And importantly, children are more likely to have long-term complications related to an implanted ICD. And this needs to be taken into account when evaluating the risk to benefit ratio for ICD in children with HCM. There's some really unique considerations. For example, their small size. Where's the ICD going to be placed? Is it going to be in the abdomen? Is it going to be in the chest? Is it going to be subcutaneous? Kids are growing, they're getting taller, and because of their linear growth, they're more prone to having lead fractures. They often are going to outlive their generator, so you have to talk to the family about the need for multiple generator replacements. If they have a transvenous system, they're more likely to have venous occlusion. And what's a big issue for a lot of families is the inappropriate ICD charges. I'll just say that in children, if it's a secondary prevention, meaning they've had a sudden cardiac event, ICD is always indicated. And then we also consider it in children for the very high risk patients. And we're still relying on our American and European guidelines to help with ICD implantation, but I think that there's a lot of work still to be done on really identifying risk factors in children. And then finally, as part of the management, we really try to get family screening of the first degree relatives. Usually not a problem for the siblings, but interestingly, sometimes I have a hard time encouraging the parents to get seen and screened. A lot of times they come to us because a grandma or grandpa has it, and so they get the kids screened, but they don't get themselves screened. And we really spend a lot of time explaining to them that it's really important for the care of the child that the parent is also taken care of and is getting the appropriate follow-up. A lot of times they tell me, oh, I had a normal EKG in the past, but that's not good enough. So I give them the numbers of my colleagues over at UCSD, and I make sure at the next follow-up that they've been seen. There's a lot of issues with childhood obesity, especially during the current pandemic, a lot of sedentary lifestyle, poor dietary habits. So we really try to tell our families that they need to establish a healthy diet in childhood, that obesity has worse outcomes in this disease. So whether that's getting them involved in nutrition early, but we really try to manage their weight and diet early. We tell them they must go to their regular pediatrician visits. They must have their routine childhood vaccinations. And then, of course, as already been talked about, activity restrictions, we do advise them to stop their competitive sports. So that's pediatric hypertrophic cardiomyopathy in a nutshell. Thank you very much.
Ooh, it's feeling a little Halloweenish over here. It's happening. You ready?
Oh,
Boo. Ladies and gentlemen, those who are squeamish should look away.
Look at that.
The crazy lady has a heart in her hands. I figured it fit for tonight. We were talking about transplant, and this is mine. So we're going to take this Halloweeny scary moment where I have my bag of human organs. Yeah, people, I really need a hobby. We know that, right? But this is my actual heart. And because we were just talking about LGE and we were just talking about children, this is, okay, so y'all know that I had HCM. I was diagnosed at 12, a child with HCM. I had 5 defibrillators. Wait a minute, Batman's here. I didn't know Batman was here. Batman's here too. This is so awesome. Okay, so I was 12 years old when I was diagnosed, and Batman was the first person I actually told because she was in the hallway when I found out that I had a heart murmur, and I knew it was in the family. So I was a child with HCM. I was an ICD patient times 5. I've had every medication you could think of almost, and I had a transplant. So like I'm the poster child for tonight. So if you look very closely into this wall of the heart, you see areas of white and striation here. That's fibrosis. That's LGE in the real form. So it's absolutely amazing to me that this thing kept me alive for 48 years because look how tiny the cavity is. It's all muscle. So there was my goofy little Halloween thing for you guys. I'm going to keep the hat on because I just think it adds to the, the attitude of the season. So thank you so much for those great talks. We do have some questions for you. That was my moment of levity. So we have some questions. And I'm just going to take them randomly. And if you have additional questions, please ask. We will stream through Facebook for these questions. And in a moment, I think we're just going to stay in this room and we're going to turn off the video and audio in a few moments. And we will take verbal questions from our crowd. If they want to raise, they'll be able to raise their hand and ask a question. But for right now, we'll do the Q&A in the box. What are the predictive factors for patients to develop heart failure? Eric looks like he wants to talk on that one.
Good. I think that's actually a really good question. There are some genetic mutations which seem more likely to progress onto heart failure, and Gabe was talking about TNI3, the thin filament mutations. They seem to more commonly develop heart failure. The sarcomeric mimickers, or they seem to develop more commonly to develop heart failure. The development of gadolinium, so the MRI seems to help predict who's going to develop heart failure. Atrial size, I think, can be a harbinger of ultimately of. It looks like atrial size may be a predictor of arrhythmia now. That's as potent as some of our other findings I've seen, and then also can be a predictor of heart failure. I don't know, Jorge, other things?
Yeah, I mean, I think of people that are not well diagnosed of having obstructive forms of the disease, with not doing proper provocations or exercise testing. They can go mismanaged or mistreated and develop eventually heart failure symptoms. Now, one thing is to say is heart failure symptoms, and the other thing is when we talk about heart failure symptoms, people picture those are large hearts and boggy hearts and very weak hearts, but in HCM it doesn't happen that way. Just the fact that your heart is very thick and not able to be sufficient to pump blood for your daily demands, that's already a symptom of heart failure. And also, as Eric mentioned, some mutations can lead for your heart to become dilated and become boggy from the process of scar tissue. And sometimes when the heart just remains thick, if you're always obstructing or your pump is not very efficient, that will lead to a significant amount of heart failure. So in case of when you've done all the extensive testing for provocation of obstruction and you really do not have obstruction, those people tend to end up having heart transplant more often than not, than compared to the obstructive form, because as the obstructive form, we have options of reducing the thickening of the heart, or we have medical options to just improve the efficiency of the pump. But the non-obstructive forms, they end up having more issues just with the function, the relaxation, and eventually end up in transplantation. And then you saw the case that Dr. Adler presented, right? A patient that underwent multiple myectomies and her heart condition just continued to progress. Eventually that also developing worsening heart failure and more symptoms.
So I think the other thing that I would caution on is while ejection fractions in HCM are normally high or super normal, when your EF changes, you're going to follow this number over time. I will tell you that 6.5 years before I landed on a transplant list, I knew my ejection fraction had gone from like 65 down to high 40s, 50. And I stayed around that 50 mark for a while, which to a normal heart is fine. but 50% of nothing is nothing when that cavity is so tiny.
Right.
So my EF was low. And if you look at Barry Marin's original data, time to transplant or death after an ejection fraction has hit 50 or less is 7 years. I was 6 years and 7 months when it's like, okay, we hit the wall, we've got no other options, and we went to transplant. So there's something to be said about statistics. I know people have gone much longer, but it's a marker to watch your ejection fraction and keep an eye on that number. And I think left atrial dimension is a real good indicator that things are not going in a great direction if that left atria is getting larger. So you want to keep an eye on that. And this is where high volume center matters, because these factors, well, your EF's 55 and your left atrium's, 5.2. It's not terrible. And those numbers don't sound horrible, but in the context of HCM, they're leading the wrong direction. So we have another question. An individual is non-obstructed HCM, has had heart failure symptoms, and wants to be involved in your wellness and exercise program, but they were turned down because their ejection fraction is too high. Is there another pathway that they can go through to get involved in the exercise and wellness program? Or do we need to reevaluate how we're evaluating HCM patients for that program? I don't know the parameters of the program, so help.
Well, typically, insurances cover the rehabilitation, whether you had like heart surgery or you have heart failure with a very low pumping function. If you had any interventions where they put some stents into your blood vessels, or they do some sort of surgery to your heart, you can qualify for that. But the other options is that some cardiac rehabilitation programs like ours, they have an intensive pathway where they also cover like your diet, your psyche, your things that are stressors and poor motivators to make sometimes like poor choices, but those symptoms are not covered by the insurances. However, you can still go to those centers and get evaluated and get managed and give you a prescription for exercise. So there is value in it if you have the means to do it. I think it's highly encouraging, because doing exercise in HCM, I think, is also a key component just to improving quality of life in general.
I think we could make a decent argument if we could publish it to just have insurance cover a short time of exercise, maybe 2 weeks, going several times a week, just so people learn what's safe, what it feels like, knowing that they're monitored. If we could get some of those programs covered by insurance, I think it would encourage people to be more active and feel comfortable and confident in doing so. And I think that's a worthy endeavor for the community in the coming years, to try to get it published and work with the insurance providers to say, look, you get us moving now, we're going to have better quality of life and less hospitalizations later. So let's save the money on the front end and pay for a couple of visits and share on that one.
Well, especially since the ball has moved so much about exercise, as you know. Like when I was first doing this, we were told people like, you can play ping pong as long as it's not vigorous. Like you can bowl, but the ball has to be light. And now we're telling people, we want you to exert yourself and doing things, but rehab, in theory, specialized rehab could be a really nice way to tell people what, we don't want them bench pressing super heavy weights and doing CrossFit and things like that either. So I think it would have to be a specialized rehab, but I think that's a great idea, because
even if we can get a session, so people feel what their heart rate feels like when it's out. Oh, Julie chickened out to her costume if I'm still here with a hat. But I think if we could get that to happen, that would be great. And even if we can work with each institution on a case-by-case basis to, let's get a couple of sessions in here, figure out how that could work. But I think that would be really, really helpful. I know we didn't 100% answer your question, anonymous attendee, but I hope we gave you some thought. And you can pay. Just because insurance doesn't pay for it doesn't mean you can't do it. It just means you're not going to get reimbursed, which we know isn't great because we all pay high premiums out anyway. It would be nice if it were covered. So we answered that one live. Lee, if you're still with us, you're down in Australia, aren't you? You will be able to review this video later. It's going to be on YouTube in the next day or two, and it's on Facebook right now. So you can go back and review those slides anytime you want. The internet is really cool that way. Okay. Next, regarding risk factors for ICD, this is a really great question. Why is it limited to first degree relatives? Because there's a number of cousins who have died from cardiac arrest, same gene, Why is it not as relevant as a first degree relative? So the second degree relative question, which is one of my original criticisms on the first guidelines document, it was too clear that, oh, it's a first degree relative who dies suddenly, you get a device. If it's a second degree relative, it doesn't count. I actually had a very interesting situation that I believe was actually in California. The grandfather had 3 brothers. The 3 brothers had all died suddenly under the age of 45, 50, something like that. The grandfather survived, had HCM, but survived. The daughter is diagnosed and doesn't have any symptoms. The granddaughter has an amazingly thick heart and was thought to be at high risk, but not, she's like a 28, not quite a 30. So they told her she didn't have a risk factor, so she couldn't have an ICD because the relatives weren't first degree relatives who died. So how do you deal with these second and third degree relatives dying suddenly and that individual not being at risk?
Yeah, I mean, this comes up a lot for me. I'm sure for, John had to hop off, but I'm curious what Gabe and Jorge thinks. I think I'll tell you my personal approach is if I have high suspicion, I'm looking for a reason to put it in. And that may be putting a loop recorder in or having them walk on a treadmill, doing everything possible to find the 5 beats here, something that we can, so that we can kind of make a compelling case and working with the insurance companies and doing things. We just, it's a really good point. We don't know. If you have the same mutation, we don't know because it's not a first degree relative. The thought process is that you're more genetically similar to someone that's a first degree, and there's probably other genes besides just the HCM gene that influence your risk. But there's not enough data to know that. I think that's just it's a little bit antiquated way of looking at things, but that's the guidelines across HCM and DCM, and it speaks to why we need more research. But I think if you're an advocate for yourself and you're concerned, usually the doctor and between the cardiologist and the electrophysiologist, the team will do extensive testing and really look. And if there's really nothing there, the chances are quite low of having sudden death. If you don't meet the criteria, the negative predictive value is really good. That's one thing I'll say about our scoring systems in the US, even more than Europe, right? So you can rest assured. And then if you add an MRI and you have no fibrosis on MRI, you have nothing else, you can probably rest pretty assured. But it's a scary thing. I get it. I don't know how to make people. I spent an hour just a few hours ago with a patient in clinic talking about this, and the grandmother died in her sleep, never got tested. Her mom has the gene, so these things happen every day. I don't think there's any easy answers,
I think the key is following up on a regular basis, making sure you're getting your Holter monitors or put the loop recorder in, do your Holters regularly, making sure that you don't wait too long between visits. You may not need an MRI every year, but every couple of years, if there's a high risk, we're still figuring out what how long between MRIs to see how scar is developing. All of these things come into play. There's a follow-up question on that individual question, and that is, I think he was referring to risk factors for sudden death. Is the septal thickness before or after myectomy? It is maximal thickness at any point in your life, regardless of intervention. So if you had a 3.2 centimeter septum and they shaved, it back to 1.6, you still had a 3.2 centimeter septum, and that's what your risk factors are going to be based upon. Correct?
Right.
Yeah. I mean, I think there's a thought that myomectomy prevents sudden death. We just don't know that. The treatment to prevent sudden death is a defibrillator right now, and you need to at least have your risk factors reassessed after myomectomy. And if the risk factors are there, including the biggest septal thickness, then you should still have a defibrillator, in my opinion.
Okay, we're rounding up to our last 2 questions. So if anybody else has any questions for the public, we're going to go through 2 more questions, and then we're going to cut the feed and cut the recording, and then we'll just do questions with that recording. Regarding transplant, once diagnosed with end-stage HCM, are the specific progression indicators which point to the likelihood of progression to transplant. Example, EF reducing, AF start. We actually did cover this one. So when do you know it's time to have an amicable divorce from your heart and put her in a box?
I can take it on for adults, and then maybe Gabe, I'm curious.
Gabe just went, did you
kids.
just say amicable divorce
I
from a
think,
heart
you
attack?
know, at the end of the day, we can do two things. We can make people feel better and live longer. And so, and in hypertrophic patients, it's leans a little bit more towards, can we make people feel better? You know, a lot of our, you know, it's patients who are having really bad quality of life where the risk of the heart transplant is still worth it. So sometimes it's just sitting to get to know your patient and they're really suffering. And, you know, Lisa and I have talked about it. You know, sometimes these patients are not taken seriously with hypertrophy. You know, they have terrible chest pain and they just get cast and say, oh, this patient's just seeking drug, you know, all this stuff. They don't understand how bad the quality of life is for our patients. And so I think that's a big component of it. And then I think all these things you mentioned, this anonymous attendee, these are right on. These are the risk factors we think about. And as I mentioned, the traditional ones might not be the ones you think about, like not doing well on the exercise test, especially in kids, may not be as important. The later we can go without a transplant, the better, in theory, because we, you know, they have a lifespan, the donors, but we're now seeing people 30, 40 years after transplant. So I think that's better and better. I don't know, Gabe, how do you have this discussion with patients and families?
Yeah, sorry, just making sure I'm unmuted. You know, for the most part, when we're transplanting in children, it's usually the burnt out hypertrophic cardiomyopathy. So the muscles burnt out, the ventricles dilated, the function's gone down, and they've progressed to, you know, having pretty significant heart failure symptoms from a burnt out HCM. That being said, I've also transplanted for rapidly progressive hypertrophic cardiomyopathy that obliterated both the LV and the RV cavity. And so the child had symptoms of heart failure just from pure obliteration of the ventricular cavities. And so we had to transplant. We got lucky. We got a heart in time in that case. Every time we looked, it was getting worse.
And in Danon, we see them in like age, you know, 9, 13, 15, you know, these just tremendous hearts in a really young age in the sarcomeric, the Praxis and the Danon diseases were, and arrhythmia too, like, so patients were getting tons and tons of ventricular arrhythmias.
Yeah. I would say also, I guess because our background training of Eric and me and advanced heart failure and transplant, we kind of become more sensitive or sensible to recognize end-stage disease symptoms, and we have the tools to diagnose those by doing invasive tests and see how much the blood is the heart is squeezing and see how much oxygen the heart is consuming. So all of those factors we integrate in the evaluation as well, and see if your heart has reached that point, and transplantation is probably then the next step.
So the follow-up question here, the remainder of the question is it usual for someone diagnosed with end-stage HCM in their 40s to stay stable for a normal lifespan?
I think with newer therapies, we expect many HCM patients to have a normal lifespan and not require transplant. You know, you mitigate risk of sudden death, you do medical therapy, and you should have a normal lifespan with HCM. Especially, and with myomectomy in the right patients, we're seeing also there's some data. It's not randomized and it's not perfect, but
they're talking about they're already
yeah. When it says end stage HCM, then that implies by definition it's end stage, and that implies no, right? That means
7 years to transplanted death on average.
Yeah.
So we need to keep a very close eye. I want to talk about pediatric transplant for a second, because there was a very cautionary tale that happened a number of years ago. It was just the anniversary of the one young boy's passing. It was a child who was told by a local cardiologist that, oh, it's just HCM, it'll be fine. But restrictive physiology was identified quite early. And the boy, around Halloween, walked out of the bathroom and fell into his mother's arms and passed away. And I think he was 7 or 8. His little sister was 4 or 5 at the time, and we got them to a center of excellence for an evaluation, and she was already showing restrictive pattern. Turned out that they had a double gene mutation in the family. So this was pretty significant. The little girl went for transplant, did very, very well. I'm happy to say last summer, her and her family were vacationing in the area. So we got to go out to dinner together, and she just had her checkup, and she's doing well several years post-transplant. And it matters if there's restrictive physiology in these kids. Yeah, you want to comment on restrictive HCM in kids?
Yeah, so that was one of the objectives of the PCMR when they published a follow-up study a few years later. So they showed that in one of the subgroups they identified, they called it mixed cardiomyopathy. So if you're a mixed phenotype having hypertrophic and restrictive, just that one alone, without any risk factors, it was a 25% probability of death or transplantation. If you added in one risk factor, which for that subgroup was young age at diagnosis, heart failure symptoms, or an increased left ventricular posterior wall thickness, in those cases, about a 58% probability of death or transplantation. And then if they had 2 risk factors, it was 71%. So this was definitely a very high risk category. And one of the reasons I think the PCMR was so helpful was because it was, you know, when you find a diagnosis, it really kind of helps you judge your clinical follow-up. And like that was someone that you know, we would have watched extremely closely, knowing that if they're a mixed phenotype, they have a high risk of death. And so they need to be monitored closely. And what I found valuable about this is you start the transplant discussion early when they show up with a mixed phenotype, whether it's mixed hypertrophin restrictive or if it's mixed hypertrophin dilated.
Completely agree. So I will ask this next question, and I will note that one of our faculty members is a consultant for MyoKardia, and MyoKardia is a sponsor of the BigHearted Warriors Tour, and it is a question about mavacamten. Will mavacamten lower ejection fraction? If it does lower EF, then wouldn't it be an option? Then it would not be an option for normal low EF patients. So can somebody discuss the mechanism in which mavacamten has been successful in reducing gradient, and what does it have to do with ejection fraction?
Yes, I mean, mavacamten is like the other drugs used for heart failure, in that, I mean, for hypertrophic cardiomyopathy, in that it helps the heart squeeze less hard. So but it works in a unique way in that it prevents the, you can think of the heart as kind of overlapping Velcro. It's grabbing itself and letting go, grabbing and letting go. And mavacamten kind of prevents that Velcro from binding to itself as efficiently and as well. And because of that, the heart doesn't squeeze quite as hard and blood can get out, and it prevents obstruction from occurring within the heart. The problem with that is that, I wouldn't say a problem, but as a consequence of that, ejection fraction in some patients has been shown to be lower. So in the trials, it didn't seem like it's significant, but there were some patients it was noted to have some drop in ejection fraction. So if your ejection fraction is already a bit lower, we don't know. We're waiting for the FDA to approve the drug. And I mentioned in my disclosures, like I've done some consulting with them. So I'm not a stockholder or anything like that.
Too bad for you, because they just sold for $13 billion.
I know, don't rub it in.
I can't buy it either, so
yeah,
I'm in the poorhouse too.
But the bottom line is, I think if you were going to have a low EF and take that drug, you're going to want to watch pretty closely. That's the bottom line. And then see if your EF drops more. Most of the people whose EFs dropped didn't have symptoms. They're just EFs dropped on paper. So, but some did. So I think it might not be an absolute contraindication, but it might mean that your doctors are going to watch closely if you start it. And the nice thing about it is it wears off really fast. So if you start it and your EF dropped, you could stop it and your EF would probably recover.
You can do a washout. Okay, we're going to say goodbye to our friends on Facebook right now. So goodbye, Facebook. And